and ESC Medicam's 4K endoscopy. So this is how the 3D imaging works. So laparoscopic recorders, specialized devices designed to capture HD video and images during surgeries for documentation, compatible with the standard surgical cameras and can record in full HD and 4K resolution. Connectivity, common interface include HDMI, SD and AV, allowing connections to monitor. Recordings can be saved directly to USB driver, SD cards and DVD. So this is an integrated 3-in-1 endoscope camera system. So light source, camera and the recording system. So insufflating system comes with the two CO2 cylinders. They are available in different sizes. So 5 levels, 7, 10 and 15, 20, 35. Carbon dioxide gas is the agent of choice due to its low risk of gas embolism, rapid reabsorption, low toxicity and low cost. It inhibits combustion. So this is a CO2 cable which is flexible, high tensile strength, deliver gas from insufflator to interperitoneal cavity. So insufflator parameters. So this is the insufflator. This is the insufflator which has increased and decreased the pressures, and this is a varies and trocar this thing. And so usually when we initially do the pneumoperitoneum with varies, we place in a varies mode. So it delivers 2 liters of this thing per minute. So limitations of insufflator, a pressure of 4 mm of Hg is more depicted than the actual pressure. If pressure is more than 25 mm of Hg, compression of IVC, DVT and air embolism, surgical emphysema risks are present. So this is how video play.
Sir, we're running short of time. We may have to shorten it, please.
Instrument of access, this is a varies needle. It has outer hollow needle with sharp beveled edge and inner spring-loaded rectangle blunt operator. This is the technique how to introduce a varies needle. We have to see 2 pops and a click. Hastens to gain initial access to abdominal cavity with open cut down method. This is a Hasten cannula and this is the technique open method. And this is a VISI port. Optical trocar allows visualization of tissues as the blade cuts through the walls of abdominal layer. Trocars. So this is the 5 mm and 10 mm trocars. These are the disposable plastic and apple trocars. So there is a reducer to decrease the size of a trocar from 10 mm to 5 mm. So operative instruments, good qualities of laparoscopic instruments are 33 centimeters long, jaws to be adequately elastic to perform atraumatic surgery, easy to disassemble and reassemble, easy cleaning, simple design with minimum number of hinges and bolts.
Can we move on, please? Thank you.
Yeah. So these are the instruments. Needle holder, suction cannula, energy sources. So port closure. So there is a laparoscopic stone holder, clip applicator, myoma screw, morcellator, tacker, specimen extractor, endo bag, hemolock, staple devices, retractors, uterine manipulators. Thank you.
Thank you very much. We'll move on as we are running short of time. Next topic is creation of pneumoperitoneum by Dr. M. Sarvani. Please.
Can I use it? దీనిలో పెట్టేసాను. Good morning all. Today my topic is a safe technique. Everyone want to be safe. Huh? So, well, we have learned about the instruments and we have seen about the what exactly history of the laparoscopy, and now we want to have a safe technique. Everyone want to give a good benefit to the patient, right? And all the budding surgeons and all. So initially you started your hospital and you have all the equipment, and now it is time to start. This is actually the base. So the starting, the creation of the pneumoperitoneum. Before creating the pneumoperitoneum, everyone should have a good history of the patient, which is very important. What exactly the patient is presenting with, and you have to examine the patient thoroughly. You have to examine the scars, so that it will give us an idea where exactly to put the port, and to give a safe outcome to the patient. So this is very important. So before going to my topic, so that I want to tell you is history is the main, and every surgeon should take a proper history. And so the techniques, as you all know, the varies needle, everyone will be having this, and the open technique is the Hassan technique and the direct rocker technique. It is a spring loaded needle which was first developed in by Varis. He invented for a pulm. He is actually an intensivist, and this he used to collapse the lung. He used this Varis to collapse the lung. So it is one of the old and traditional technique to enter the abdomen. So how we need to hold the needle? How you hold the dart? So you want to enter it, right? So where exactly you want to enter it? You have to focus on the target. So you have to hold like a dart, or some people they can hold like a pen too. So the size varies from 8 to 20 centimeters. So 8 centimeters is used for the pediatric case, and the 20 and above it was used for the obese patients. So it's have a sharp outsheath and a blunt stilet, so that it's not going to injure the abdominal organs. And as soon as it passes through, so it retracts. So the spring towards forwards, when the tissue it has the resistance that drops. So this is the parts of the needle. So you can see the down picture. You have that spring action. So there are the other types like disposable needle and reusable needles too. I generally use a reusable needle. I don't go for the disposable one. So the safety technique and checks is, so as soon as you enter the abdomen, it gives a double click, and then we do aspiration test, then his test, syringe test, and needle wagging test and all. Sorry. So the aspiration test, as soon as you put the Varis needle, you need to apply some saline. So, and or air is aspirated to check whether it is in the position or not. If the content is a bowel or a urine, you just need to remove the needle. this is what is the books or whatever you say. But if you are like, after your progress, I mean, if you get expertised in your field, you just can introduce another like choker in a safe zone, and you can visualize what you had injured it, whether you had injured a bladder or a bowel, so that you can repair it on the table itself. If you're, I mean, if you're good at suturing and all, so that prevents like laparotomy. So if you see a blood, then if it is like a heavy bleed and if vitals are unstable, then you go for laparotomy. The safety test is a hanging drop test. So you introduce a drop of water, and when you elevate the abdomen, so automatic the water gets disappeared because it goes into the abdomen. This is the needle wagging test. It is free, so that needle will be in, you mean that its needle is in the position. So when you aspirate a blood or bowel contents, you can see in that of the needle. So these are the incision, where to place the port. So most of the people say like Palmas area is the best area, because there you won't injure the bowel or anything. Any area, two things to be remembered: ask your anesthetist first to put a Riles tube and a catheter. These are very crucial steps, and these to be followed by every initial days, not only initial days, at any part of this, throughout your lifetime, because these are the two areas. Whenever you put a port, either the stomach or the bladder gets injured. So these two things are important, like nasogastric tube and catheterization is most important thing. Even though you ask the patient like to void and to come back, sometimes they won't. So it is better to do. So Palmas area. And one more safe is the epigastric port. There, I mean, epigastric area is also a safest thing. Only thing is you find only a falciform ligament over there. So the chances of injury is also very less. And the other one is the umbilical. So all the pelvic surgery, you can put the varus needle at umbilical port. I just put a question to the, PGs. If there is a scar beneath the umbilicus, so where you wanted to place a port? Or varus needle? Palmar space. Okay. Or epigastric area. And also remember to direct the port. Sometimes, suppose if you are placing an umbilical varus needle, you just can direct towards towards epigastric region too. So that also sometimes avoids injury. Suppose there is a small scar like tubectomy scar or anything. So if you want to place an umbilical port, because it is a little bit far away, so you may feel that there won't be any adhesions. At that time, you just, to be little more confident enough, just direct the varus needle towards the epigastric port. This you develop through, after doing cases. So that will prevent entry into the bowel, or it doesn't cause any, it doesn't enter into the omentum space or anything. So another reliable safe test is intraperitoneal pressure test. It is the most reliable method. So the pressure usually is we maintain like 10 to like 16. So usually the insufflator, it insufflates with 1.2 per liter. So it confirms it is in the varus needle is in the correct position. So to avoid risk, so undo long needle and premature Trendelenburg position and improper insertion. And I told you earlier, put a nasogastric tube and a catheter. So direction of entry, it should be 45 degrees, so that and pull the abdomen above so that it will avoid injury. During the elevation of the abdomen, so so the prevention of the whatever the vessels and all, it will be prevented, because the abdomen raises about 0.1 to 2.5 centimeters. So even towards the sacral hollow median also. Usually the first trocar and all that causes most of the bowel injuries. So there are some, based upon the BMI also, this can be modified. The entry, the angulation of the port entry, you can adjust based upon this. So how do you feel, I mean, how do you create like initial step of creating pneumoperitoneum if in case of a failure? So if entry of the pneumoperitoneum, if the needle, if it is empty.
Sorry
So
to
you-
interrupt, we have got just 2 more minutes to go.
Okay, sir.
Thank you.
Mediastinal emphysema and omental emphysema, but these are all, it is okay, like you can correct them. And pneumothorax, this is also possible. And if it is entering the blood vessels, it may cause embolism and death. So, as already told, carbon dioxide is the most commonly used. So, the trocar tips also, it is like a closed or an open. As I told her, I mean, prior told her about a Hudson technique. And this is an open entry technique. This is a Hudson technique, which a small incision is made and directly the port introduced into the peritoneal cavity. So the direct entry port, after get expertized, so you need to put an umbilical incision and then directly put the first trocar. This would be better if you place a Veress needle and then you introduce the port. Sorry. So these are also, it may cause much damage to the viscera and all. So most important thing is when you recognize the injury, try to record the errors. You maintain a book so that when you can learn through your mistakes. So this is the opti-trocar. I'm sorry, the video is not working. So the key points is most important to have a clear picture in mind. What exactly you want to do and where you wanted to place a trocar and obtain a proper history of the patient. And so the complications rate will be lessened. And the initial phase of laparoscopy, yes, the injuries will be there, but don't panic. Try to learn from the mistakes and maintain a record. Thank you so much.
Thank you very much. We can have any questions later on after the session is over in the break, as we are running short of time. I call upon the next speaker, Dr. Sri Krishna Natraj, tips in placing the ports. Thank you.
ఇదా రిమోట్ ఏం చేయమంటారు ఓకే ఓకే వెనక్కి వెళ్ళిపోతా ఉంది నొక్కేసారు మొత్తం వెళ్ళిపోతా ఉంది
I request the speakers to please curtail your lecture within 7 minutes. Thank you.
Good morning, everybody. Myself, Dr. Krishna Natraj, surgical gastroenterologist practicing at Ongole. So today I would like to talk upon tips in placing the ports. So imagine a surgeon is ready for a laparoscopic appendectomy, and when he inserts the first port, he sees a gush of blood into the trocar, or immediately after inserting the camera into the abdomen, entire abdominal cavity full of blood. So this is a very horrible situation, and no surgeon wants to be in such a situation. So the seemingly simple steps are at times very dangerous and very complicated steps, and we should all practice safe techniques for introducing ports. So as we all know, the initial point of entry after creating pneumoperitoneum is placing the ports, and oftentimes this is the most dangerous step in the laparoscopy. So there can be damage to the underlying organs like bowel, mesentery or omentum, and very rarely there can be major vascular bleed leading to even mortality of the patient. So unfortunately 30 to 50% of the bowel injuries and up to 50% of the vascular injuries are not diagnosed at the time of injury, and this contributes to late mortality. So as the previous speaker has told, the ways of entry into the abdomen are closed insertion with pre-insufflation and the open Hassan technique, and without pre-insufflation the direct trocar entry. I would like to emphasize the entry technique with pre-insufflation. So what is the site of initial placement of initial trocar? So usually in most of the cases it is peri-umbilical position for obvious reasons, because it is the abdominal wall is very thin there, relatively avascular, and for most of the surgeries the telescope port can be placed at the umbilicus and the surgery can be carried on, except for a few cases like laparoscopic Nissen's fundoplication or achalasia cardia, where the telescope port needs to be placed higher up and to the left of the midline. And mostly the cosmetically acceptable scar also favors the periumbilical position. So whenever, what are the contraindications for the periumbilical position? Whenever there is a midline scar, it indicates that the previous laparotomy has been done and there is a chance of adhesions and we cannot place port in the periumbilical position. So the alternative points, as the previous speakers told, the Palmer's point is a very good point for safe entry into the abdomen. And mainly in portal hypertension cases, the para-umbilical veins will bleed torrentially when the initial port is placed at the umbilicus. So it has to be taken care of. So the type of trocars, we can see the bladed trocars where the tip is very sharp and it pierces the tissues and creates entry into the abdomen. So a modification of these trocars is a safety valve trocars where the blade is surrounded by a blunt tip which is attached to a spring. So and there is a blunt trocar. So the types of insertion: direct insertion into the abdominal cavity and the Z technique. Initially the Z technique was described to prevent the gas leak and to prevent incisional hernia, but practically nobody uses it. And this is the technique of primary insertion, primary port insertion. So the patient should be in horizontal position, and the main important point is the skin incision should be at least 1 to 2 millimeters more than the size of the trocar. So many times people struggle to place the port and they use pressure to place the trocar, initial trocar into the abdomen because of small skin incision. We should always remember that minimal invasive surgery is not a cosmetic surgery. 1 or 2 millimeters of excess skin incision is not going to do any damage to the patient. And after giving the skin incision, liberal skin incision, subcutaneous fat is spread out, and the good technique of holding the trocar is with the thenar eminence of the palm, and the thumb and the middle ring and little fingers are holding the trocar, with the index finger acting as a safety guard. So the upper two pictures are the correct ways of holding a trocar, and the lower picture is an incorrect way of holding the port or the trocar, because in this case there is no control upon the pressure exerted on the trocar, and this can lead to inadvertent vascular injury or bowel injury. So always it is a good practice to hold the abdomen and pull the abdomen up while inserting the trocar. Sometimes in obese individuals it will be difficult to hold the abdomen up, and you can take the help of the assistant, or you can use towel clips. You can use towel. Towel clips can be used to. No, back. Okay, no. Back So you can use the towel clips to increase the space between the abdominal wall and the viscera. So once the So we can use the towel clips to hold the abdominal wall up and have some good space between the abdominal wall and the viscera. So a constant pressure is applied on the trocar, and with rotatory movements, once the linea alba is penetrated, the trocar can be directed towards the anterior abdominal wall or in 45 degrees position to avoid the injury to the bowel. It is always safe to have a small gas leak at the port site rather than having a major vascular bleed or a major bowel injury inside the abdomen. So whenever you find difficulty in inserting the trocar, please come out, check for the skin incision, give 1 or 2 millimeters of extra skin incision, and the trocar can be safely inserted. So this we can see here, the usually the umbilical point corresponds to the bifurcation of the aorta. So in very thin individuals, there is a danger of vascular injury when the trocar is introduced vertically. So in particularly in thin individuals and children, the trocar has to be inserted at an angle of 45 degrees. But in the cases of obese individuals, usually the umbilicus is at a lower position and the trocar can be safely introduced 90 degrees. So once the primary port has been placed, it is a safe and good practice to insert the camera and look for check the confirmation of port placement into the abdomen before connecting the insufflation. So once the primary port is placed, the secondary ports are placed under vision, and the placement of secondary ports depends upon the type of surgery to be performed, and the angulation and all those things will be discussed in the ergonomics. And now I will just tell the port placement techniques. So in the same way, the trocar is held in a proper position, and under guidance the trocar is inserted into the abdomen. When the trocar is about to pierce the peritoneal cavity, you can see a dent. At that point, you can direct the trocar away from the viscera, and it is always a good practice while the trocar is entering the abdomen. So it has to be in the field of vision. It has the camera person has to show the field of entry of the secondary trocar. So a few problems we encountered during the placement of secondary ports. So when the tip of the trocar is too close to the underlying viscera, there is a chance of damage to the underlying viscera, and we can, in such cases, we can hold the abdomen up and then place the trocar safely. Sometimes we can change the direction of the trocar. When the trocar is in oblique position, you can change it to the vertical position, so that when the trocar is in vertical position, you can change it to the oblique position where the trocar will be moved away from the viscera. Aligning the trocar parallel to the abdominal wall is also a safe procedure to do in such cases. And sometimes you can direct the secondary trocar into the primary port, slowly withdrawing the telescope to avoid injury to the underlying organs. And when the in obese individuals or in children, we can see the peritoneal movement ahead of the trocar. Yeah, I just 1 minute and I will finish it. So in such cases, we can change the direction of the trocar, and we can use instrument to score the peritoneum and enter the abdominal cavity. So bleeding from the trocar site, it can be changed, it can be stopped by using pressure. So this is the most common technique we use is the direct penetration technique, and the open Hassan's technique, everybody knows this. Rectus sheath is open, and the finger is used to enter the abdominal cavity, and then a blunt trocar is placed into the abdominal cavity and fixed. So thank you for your patient listening.
Thank you, sir. Now I would like to call upon Dr. Srinivas Iyer to talk about tissue handling and energy sources in laparoscopy.
Yeah. So today I would like to talk upon energy sources in laparoscopy. This is one of the actually when I was preparing the slides, I understood out that how much naive I am in actually learning the concepts of this. Believe me, this is something like everybody knows something about it, but nobody knows everything about this topic. So here I would like to start with the classification of this based upon the principles that we do. Here, first principle is electricity is converted into heat. The second type is electricity is converted into high frequency waves, which in turn gets converted to heat. Electricity is converted to ultrasonic frequency, leading to mechanical energy, which causes friction and thus is used for energy devices. Focused light energy, which is then converted to heat. And finally, electricity to ultrasonic frequency, wherein the cells are broken down and are aspirated. So the examples of these principles are, first is cautery, second is electrosurgical unit, ultrasound, laser equipment, radio frequency devices, plasma and argon beam coagulation, microwave devices, hybrid energy devices. I would like to ask, how many of you all have seen this thing? This is actually an electrocautery unit. This is not electrosurgical unit. The basic difference here is that this uses a direct current. This is used by dermatologists to excise out the wart. So what happens here is that this uses a direct current which is in a continuous flow, which actually heats up the coil, and by this coil you score out the wart. So something similar to your cigarette lighter that you have in the shops. Okay, something similar to that. Before I go with this electrosurgical unit, yeah. So this is our nerve nerve conduction, wherein the stimulation is transmitted from the nerve to the muscular part, and the contraction is generated. Here, how many of you know that? Okay, just a question. How many of you know how much is the voltage and how much is the hertz frequency that we are getting in our normal domestic source? We get at around 60 hertz. Why is it at 60 hertz? Normal conduction is at 5 hertz to 60 hertz. Because of the 60 hertz current, you are thrown off when you get an electric shock. You have a sensation. However, the maximum sensation which can be stimulation is seen in the nerves of the brain, which is 200 kilohertz. Our electrosurgical unit works at above 300 kilohertz. So when it goes above 300 kilohertz, it doesn't work at the action potential generation. So there is no sensation felt by the patient and no nerve contraction is seen. These are basic parts of electrosurgical units. I am not going much in detail about this. What are the thermal effect of tissue based upon the heat generated? So at 40 degrees temperature, there is no effect to the cells. When the temperature raises from 40 to 50 degrees, there is initial tissue damage and edema formation. These changes are reversible. Now, as the temperature goes above 60, irreversible changes sets in. At 60 degree, irreversible protein denaturation and coagulative necrosis sets in. By 80 to 90, total desiccation of tissue, carbonization, which leads to drying and shrinkage of tissue. At 100, we have vaporization leading to cellular destruction, and at 120, you have charring effect. We know that whenever we use a cautery, sometimes the tissue that we have burnt gives out a popping sound, thup. That thup is because of vaporization and expansion, leading to sound generation. Electrosurgical unit works upon the principle of Joule's law of thermodynamics, which is heat generation is equal to square of the current which is used out, the resistance of the tissue, and the time of exposure. Factors which determine the effect of our electrosurgical units. It is current density, how much current that we are using out, how much time that we are exposing it to, what is the electrode size. Now you might have seen most of us are using out a flat plate electrode. There are certain times we use out a pin electrode, certain times we use out a ball electrode. There are various reasons why we use out, because if you are using a ball, it is for coagulation part. For cutting purposes, the smaller the electrode it is, the more current it can be delivered and more concentration is there. And tissue conductivity. It also depends upon the tissue size. I'll be elaborating it as we go, and current waveform based upon what wave we are using. Okay. So here, based upon these tissues, how much resistance is generated, you will understand out. Fat has maximum conductivity, whereas the blood has the least conductivity. Why? The blood actually keeps on flowing up, so the electrodes, like the charging part goes off. That is why they do not conduct out electricity much. Whereas the fat, they are stagnant and they have more of water, so hence conductivity is higher in them. This is a small video which I am playing, which will show how the tissue actually works out. So now here there is a sausage which is being exposed to electrocautery. The current is passing down. There is a small narrowing there. Where there is a narrowing, current concentration is seen, and there immediately the tissue rips off. The same thing applies in our laparoscopic surgery also. Whenever we do a cholecystectomy, if there is an adhesion around, and if we happen to use a cautery there, it is not the site where we are using the cautery, but where it is attached. The thin part is which gets affected more compared to the site of action. Various waveforms and the modes that we use out. We use out a cut mode. Cut mode is again divided into a pure cut and a blend mode. Pure cut is low voltage, continuous current, whereas blend is slightly higher voltage but intermittent. There is intermittent break. I'll be elaborating it in the next diagram. Whereas the coagulation mode are of two types. One is desiccation or force mode, wherein the voltage is higher and gaps are more. This is basically used for coagulation purposes. And the other thing is there is a tissue penetration. There is another mode called as spray mode or fulgurate mode. Here there is no tissue penetration and there is no need of contact of the electrode with the tissue. So here maximum voltage is being used and maximum damage is seen. You can see here in this picture, you can see in this picture, you can see here that in the cut mode you have 100% utilization of the current, whereas as it goes beyond, that is in the spray mode, the current utilization is just 4.8. However, the voltage is highest here. So damage which occurring to the tissue is higher here. Complications associated with the use of electrocautery. There is no smoke without a fire. So the first fear that we have is the burns. Here there are various types of burns. This can be either a contact burns or pad site injury. There is direct coupling, there is capacitive coupling, insulation failures, surgical fires, thermal injury secondary to fiber optic cables, electrolyte and other causing conduction injuries. This is an example of pad site injury. The problem here is that there is incorrect application of pads. Generally, most of our pads which are to be used out are to be a recyclable type of one, single use one. However, since a financial constriction, we try to use out a reusable one. And the other problem is the doctor doesn't supervise out how it is done. The OT technician does it. So if your contact is poor, then you end up with something like these burns. Zones of cautery burns.
Sir, we have got 2 more minutes.
Yes, sir. I'll finish it. So Vokes and Tucker actually divided these cautery burns into 4 zones based upon the laparoscopic instrument. Zone 1, Zone 2, Zone 3 and Zone 4. Zone 1 and Zone 4 are seen by the surgeon. Zone 2 and 3 we are ignorant about where the burns is going to be. So this is an example of a direct injury from an active electrode. One second. Yeah. So in case of a direct injury because of like the zone 1, which is only visible for us, we in laparoscopic surgery we are ignorant about what our other hand is actually doing out. So here you can see that the electrode, the current is active here and it happens to touch a bowel or some organ, and there is a cautery injury. Unfortunately, these are not seen immediately at the time of injury. These are seen 3 days to 4 days after injury by a leak which can present out. You can see a video where it is, and one thing that has to be noted is after activation also do not immediately touch any organ because the heat is yet there. So you have to wait for some seconds and then you can hold the organ that you want to mobilize out. Direct coupling. We use direct coupling for our surgical purposes. This is a short video wherein if there is any bleeding, we hold it with the artery forceps and ask our sister to touch it. So this is a direct coupling which we use it for our benefit. This can occur in laparoscopy also accidentally, wherein the active electrode can actually touch either your scope or your other hand. So sometimes when we are operating upon cholecystectomy or something, we hold the bleeder and touch it with an active electrode. This can accidentally occur if the scope gets touched with the electrocautery, leading to leakage of current, leading to bowel perforations also. I'll cut short this. Yeah. Sometimes you don't need to touch this also. Yeah, I'll go with the next slide. Capacitive coupling. Capacitive coupling occurs in a monopolar device when active surgical cable is wrapped around the towel, or we use a metal trocar with a active electrosurgical unit in it, operating with a metal head prosthesis, or sweating inside the skin of a surgeon, or a metal cannula around an active electrosurgical instrument.
Crossed the time.
Just a minute and I'll finish.
Yeah,
I'll not show the video. And finally, insulation failures. This is one of the most neglected part, thermal injury in form of current, or surgeons apply cautery near the finger grasping. I'll just finish it off. Key takeaway point of the electrosurgical topic here. Ensure return electrode is in complete contact with the patient. Avoidance of spirit-based disinfectant or pooling of prep solutions. Use of return electrode monitor. Most importantly, be calm. All bleed needs patience. Most of these injuries are because of panic. So be calm. If there is need, call for help. Be aware of the surrounding anatomy to avoid unintended injury to the nearby structures. Avoid open circuits by not activating the monopolar device in the air. And avoid touching metal to prevent unintended direct coupling. Yep, I'll finish it, sir.
Thank you, sir.
Thank you.
Now I would like to call upon Dr. Varun to speak about sterilization and laparoscopy.
Okay. ఇదండి ఇదేనండి లేదా ఇప్పుడు చూడండి పెన్ డ్రైవ్ లో ఉంది
Good morning, everyone. I apologize for the delay. I am Dr. Varun. I am a consultant surgical gastroenterologist working at Macquarie Hospital. I thank the organization. The topic I am presenting today is instrument reprocessing in laparoscopy. So we need to get a few terms clear. Take care of everything. So, Spalding classified medical devices into critical, semi-critical, and non-critical. Laparoscopic instruments all come under critical instruments because they enter sterile cavity of peritoneum. They require either sterilization or a high-level disinfection. Now, the distinction between high-level disinfection and sterilization is that sterilization takes care of all living all living things, whereas high-level disinfection is partially effective against spores, not completely. Now, why do we need Why do we need to focus on this? It is obvious we want to avoid infections, particularly in laparoscopic hernia surgery. We want to avoid complications. We want to avoid complications like this, and a mesh infection, for which we have to explant the mesh, and the patient undergoes a very morbid course. So instrument reprocessing in laparoscopy consists of two critical steps, cleaning and sterilization, both of which are equally important. The cleaning part is neglected by majority of us. So cleaning involves dismantling of the instrument, washing with water again, drying of the instruments. Now, soaking the instruments in enzyme solution is important because the organic material which is not visible to the naked eye will be removed effectively by this enzyme solution. We soaked the instrument before washing the instruments, and if hospital has an ultrasonic cleaner, you can use that, but this is an expensive equipment not available to many. Thoroughly washing with water and brushing the inside of the channels of the instruments is very important during this phase. And drying of the instruments before submitting them for sterilization is very important because moist instrument can affect the sterilization cycle, especially for methods like plasma sterilization. The machine doesn't start the cycle if it detects a moist instrument in the chamber. Also, the most common method of sterilization we use is Sidex. Disinfection is Sidex, and every moist pH and concentration of glutaraldehyde thereby Now, these are the substances which can be harmful for instruments, so avoid cleaning your instruments with these. Now, sterilization can be done with a variety of methods. Any hospital which has an operation theater usually has an autoclave, and for open instruments, autoclaving them is the gold standard for sterilization. We don't need anything else. Unfortunately, laparoscopic instruments are heat sensitive, so it is very rare to subject laparoscopic instruments to an autoclave. The only instruments that I use for only laparoscopic instruments I submit to laparoscope are the ports, which are sterilized by autoclave. So ethylene oxide sterilization is another method. This is the equipment. It is expensive to buy, but it is a very effective sterilization method. Can be used for almost all instruments, scopes, cables, endoscopes, even fluids also. But the disadvantage is, apart from the expense, every instrument needs to be packed inside this sterile pouch and then inserted into the container. ETO can cause some chronic and acute toxicity syndromes in the staff which is handling them, who are handling them. It can be carcinogenic. It also requires aeration period, and it has quite a long cycle. For a hospital with a rapid turnover of laparoscopic cases, they are doing 3 or 4 laparoscopic cases in a day. This is very difficult to process them. It takes around 8 to 10 hours for the cycle to be complete, and it has to be monitored with a biological indicator. Now, gas plasma sterilization uses hydrogen peroxide. The advantage being the short cycle time at 50 degrees centigrade. For heat sensitive items, it is a very good thing, and it requires a special packing with small trays. A tray like this is used to pack all the instruments, wrap it, and keep it in the plasma chamber. The disadvantages being linen cannot be sterilized, and the cycle turns off even if there is slightest hint of moisture on the instruments. It is expensive. Both the equipment is expensive as well as the running time is also running expense is also high. Depending on the number of hydrogen peroxide cartridges that it uses during the cycle, it can vary between 700 to 2,000 rupees per cycle. So high-level disinfection germicides are the most common things which most hospitals use to reprocess laparoscopic instruments. So let us get to know them. Sidex or the 2.45% glutaraldehyde is the most common solution which is used. It comes with a 1.9% potassium nitrate 110 ml pack to activate it. And once it is activated, it has a shelf life of 14 days. The instrument, it is effective against Mycobacterium tuberculosis also, but it has to be soaked for 45 minutes. Sterilization can be done with Sidex, but with a long cycle time of 12 to 14 hours. Disinfection time, the standard recommendation is 20 minutes, but I always recommend 45 minutes because, as I have said, mycobacteria get inactivated at 45 minutes. Heat sensitive materials can be used, including our light cables and telescope, but the instruments have to be cleaned thoroughly with clean water, sterile water, before they can be used in surgery because glutaraldehyde is quite toxic in the peritoneal cavity. Another product that can be used is Parasafe powder. This is a combination of parasitic acid and hydrogen peroxide. It is especially useful for traveling laparoscopic surgeon if they are going to hospital which do not have Sidex. So around 16.2 gram per 1 liter of water is mixed. So around 5 cups per 5 liters of water. It effectively inactivates mycobacteria. It has an activation time of 15 minutes. So we have to wait until the solution turns blue, then it is activated, and then we can soak our instruments. And the soak time is 10 minutes. Once it is activated, the shelf life is 8 hours. So it can be used only for 1 day, and it has to be discarded on the same day. Another solution that can be used is Corsulex Rapid. It is a combination of glutaraldehyde and another compound. This comes in a 500 ml bottle. 250 ml is mixed with 5 liters of water. And once it is mixed, we can use it for a shelf life of 7 days. The contact time is 15 to 20 minutes for high-level disinfections and 4 hours for sterilization. One key advantage with the manufacturer claims is it has built-in cleansers similar to our enzyme solution, which help in removing the particles as well as biofilms from the instruments. Removal of biofilms is a significant advantage for this. So formalin chambers are nowadays not routinely recommended because in addition to the inadequate sterilization, they have limited effectiveness. It has a long cycle of 24 hours. Room temperature is needed. Chamber keeps getting opened by multiple people, and there will be gas leaks. It also has a health and safety risk. It is an irritant to our body tissues. It is a respiratory irritant, can cause bronchitis and pulmonary edema. It also causes increased risk of nasopharyngeal cancer and myeloid leukemia. In conclusion, cleaning is critical. Soaking an enzyme solution removes majority of organic material because if there is an organic material in the instrument before you submit it for sterilization, no method is going to be effective. No sterilization method is going to be effective. Choose the sterilization. Please consider the Sidex or the Corsulex Rapid. Monitor the sterilization process, biological indicators, and maintain a wound infection register. Thank you.
Thank you, sir, for a short and crisp presentation. This would conclude the session.
Thank you, Honorable Chairpersons, for moderating the session so well. And we thank our speakers for their wonderful presentations. Next would, since we are running short of time, we go ahead with the next session. We call upon our chairpersons for the next session, Dr. Chakrapani sir and Dr. Mahita. I request the speakers to kindly adhere to the time so that we finish all the presentations on time. So we call upon Dr. Rahman Mohammed for his presentation on effects of lab on surgeon. We
Morning, everybody. So I'll just short talk on ergonomics in laparoscopy. So this is about me. So what is ergonomics? Basically, it is a science of the work and following the natural law. Why it is useful is it optimizes surgeon's health, performance and patient outcome through evidence-based ergonomic principle. So it's basically science of work, and with the scientific study of the people at work, it optimizes the design of equipment, tasks and workplace environment to fit human capabilities and limitations. This multidisciplinary field combines anatomy, physiology, psychology and engineering to create a safer, more efficient working condition. So why ergonomic matters is for patient outcomes and for surgeons also. A surgeon who is comfortable directly affects surgical precision, reducing post-operative pain and complications. Poor ergonomics, proper ergonomics will improve surgical speed, accuracy and overall success. So ergonomics is no longer an accessory. It is an essential skill for modern surgical practice. So common challenges what we feel during laparoscopy is the static posture. So we have to just stand and operate. So prolonged standing or sitting in fixed positions will lead to significant surgeon's fatigue and muscular strain. Two-dimensional vision we have, reduced tactile feedback, and there is a lot of operating room clutter because of increased instrumentations. So what is the impact on surgeons? So recent studies have shown that the effect of laparoscopy is causing at least 75% cases are seen with musculoskeletal disorders like neck pain, shoulder pain, wrist pain. Research shows us that this diseases will increase with both surgical experience and time spent. So people who are practicing for more than 15 years or 20 years, definitely they are going to get some musculoskeletal disorders if proper ergonomics are not documented health problems we have. There is carpal tunnel syndrome, strain, visual strain, cervical issues causing spondylosis and chronic backache. Then we have upper limb pain, that is elbow pain, we have shoulder pains and hand injuries, commonly tenosynovitis and finger joint damage from repetitive movements. And these are all seen in many of the surgeons. The other aspect of laparoscopy is there is a visual motor decoupling. Normally, whenever we are operating open surgeries, our vision is directly through the patient and our hands are, so we are in a direct vision. But over here, there is a decoupling. We are seeing the monitor and we are operating over here. So this will cause patient disorientation when we are operating, and it will require advanced hand-eye coordination, which is very, very important. And the other problem is the tactile feedback problem. So there is loss of sensation. We are not able to touch what we are operating. There is a barrier instrument. A long instrument will act as a intermediary between us and the tissues. And because of this, there is an increase in duration of surgery and there is a steeper learning curve. Operating operating room challenges already said, equipment will increase. So we need a camera, we need a scope, we need electrocauteries. Okay, so multiple things are increased whenever we are doing laparoscopy, and this is called as the spaghetti syndrome. So multiple cables, tubes, and lines become tangled, creating trip hazards and limiting mobility around the surgical field. And some lighting complications also we have. Since we are operating, we ask the assistants to turn off the overhead light, which causes ambient lighting during laparoscopy, and which creates a problem of instrument handling, and also sometimes create collision risk. Staff congestion also is seen. So now what we can do is we can have the height of the table. Position the table 5 to 10 centimeters below the elbow level. Suppose our elbow level is at 100 centimeters. So the table should be at least 90 centimeters or 85 centimeters. So that is the normal height what we should have, so that our elbows are parallel to the table and it's not totally in abduction mode. So monitor placement also should be kept at the eye level, which will be at the angle of 0 to 15 degrees below the eye level to minimize neck flexion and prevent cervical strains. And whenever we are using multiple monitors, we have to place it in such a way that there is no strain on the neck. So this is how it should be. So we will have a monitor which is at the angle 15 to 40 degree visual angle below the line of sight. The table should be just 10 centimeters or 15 centimeters below our elbow level, and instruments handling at the elbow level with elbow flexion between 90 and 120 degree, and near the foot pedals or near the foot we should have the foot pedals for our electrocautery or energy devices. So that is how we have to design our OT setup. And the monitor size, suppose the monitor size is around 32 inches, so 5 times the distance is ideal. So if you have a 32-inch monitor, so our distance between the monitor and ourselves should be at least 150 inches. So that is how we should use. The ideal surgeon's posture, that is spine alignment. So maintain an upright, relaxed S-curve with normal lordosis and kyphosis. Avoid excessive bending forward or lateral tilting. Shoulder position also should be level and relaxed, avoiding elevation or asymmetry. So both the hands should be at a proper level. Now it's not one hand is above, one hand is below. So they should be taken care. Elbow should be flexed at 90 to 120 degree flexion, and wrist also should be kept in a neutral position, avoiding ulnar or radial deviations. Standing versus sitting posture. So over here, what is suggested is the mixed approach. If there is a long surgery, some surgeries can be done in the sitting position, and some part can be done in the standing position. Standing position, greater mobility and freedom of movement is there, and there is better access to patients from multiple angles, and increased lower limb and spinal fatigue will be seen. Higher energy expenditure over time. Seated position will reduce the spinal load, lower fatigue, limited reach and mobility will be there, and requires adjustable surgical chairs. This is one of the important things what we can include in our theatres, that is anti-fatigue mats. Instead of a rate of floor, if you have anti-fatigue mats, that will reduce our discomfort by 50 to 60%, and the thickness of this anti-fatigue mat should be 1.5 to 2 centimeters. Footwear and compression stockings are also very essential part of our ergonomic design. So proper surgical footwear, that is shoes with adequate cushioning and arch support. Maximum heel height should not exceed 2 to 3 centimeters. Ensure that they don't slip, because the OT rooms will be smooth. And replace footwear every 6 to 12 months to maintain the support. Compression stockings are advocated with a pressure of 15 to 20 millimeters of mercury if you are going for prolonged procedures. Port placement, triangulation, manipulation angle is very important. So this figure shows that how we should. So if we have a target organ, that the red color is our area what we are going to operate. Our optical port should be approximately at a distance of 10 to 15 centimeters from the target organ, and our working ports should be in that line of arc, at least which will be making an angle of 30 degrees with the optical port. So that is the angle what we need. An accessory port also should be in the arc laterally, the retracting ports. So that is how we should plan our surgery if possible. this many a time will not work. So that is the angle what we have, the azimuth angle. So if you have a camera port which is at the center, the angle, the working port should be at an angle of 30 degrees. Both the things should be 30 degree. So the manipulation angle becomes 60 degree, which is the ideal. So if you have a larger manipulation angle, so there is a strain on our shoulders and elbow. So manipulation angle should be kept at 60 degree. So this is what is meant by the azimuth angle, the manipulation angle, and one more angle should be there. That is the elevation angle. So how our instrument from the surface of the body should be at an angle of 60 degree. So this is what is required when we are doing a laparoscopic surgery. So instrumentation, handle design should choose instruments which are large, textured, well balanced, and distribute grip pressure evenly and reduce finger fatigue. Weight distribution, instrument should be in such a way that the weight is concentrated near the handle to reduce distal movement of and minimize wrist effort. Joint mechanics, so prefer instruments with articulating low friction joints that require minimal force for activation and provide smooth movement, and the length should be appropriate to the patient habitat and the port depth. There is something called the fulcrum effect, for which we cannot do much in laparoscopic surgery, but here what happens is procurement acts as a fixed point on the fulcrum, and small movements of the surgeon will be exaggerated on the screen. So we might have not, tremors will be very less, but when we are seeing on the monitor, the tremors will be more. This mechanical advantage sometimes can be beneficial, but also requires precise control. So one thing what we can do is we can take breaks every 20 to 30 minutes to adjust our posture, shift weight and consciously relax the shoulders. Every 60 minutes, then we can take a break of 2 to 3 minutes to step away from the table and relax. And during breaks, you can perform targeted stretches for shoulders, neck and back and properly get hydrated. Team communication is also very, very essential, like pre-operative planning, what should be the table height, where should be the monitor position should be always checked. Some members should be designated to prompt ergonomic adjustment throughout the procedure. And intraoperative feedback should be there, where the assistant or the nurse can ask whether that she is or he is having discomfort and they need to change the position, and post-operative debrief also should be done. So this is what is about the ergonomics, what we can do, and all these things will come with formal education, practical workshop, simulation training and continuous monitoring. And institution also plays a very good responsibility. Leadership commitment is essential, and ergonomics cannot be optional, but we allow it is a luxury. It is a standard operating procedure. So this is the key takeaways. It is essential, not optional. Personalized solutions are required for each and everyone. We have to embrace technology, and there should be systematic integration of ergonomics as a surgical standard operating protocol. Thank you.
That's an excellent talk on the ergonomics itself. For the surgeon will have to take care of mostly the patient, but the surgeon should be taken care of. Any questions from the floor? We go with the next speaker.
Right.
We request the next speaker, Dr. VIKRAM. We have a talk on effects of pneumoperitoneum on the patient safety.
Good morning, everyone. I'm going to discuss about effects of pneumoperitoneum on patient. Since its inception in early 80s, laparoscopy has become a widely accepted surgical approach. Smaller incisions impart several clinical benefits such as decreased pain and earlier return to preoperative activities. But it requires establishment of pneumoperitoneum, which alters certain physiological functions. There are many types of insufficient gases which can be used, but CO2 is the preferred because of its high diffusion coefficient and it's a normal metabolic end product and rapidly cleared from the body. It is highly soluble in blood and tissues and does not support combustion. Whereas nitrous, oxygen, room air are combustible and cannot be used, whereas helium has low blood solubility and has a high scope gas overburn. Physiological changes during pneumoperitoneum are mainly due to CO2 absorption and hypercarbia, a mechanical effect of neurohumoral response and patient positioning. These can be divided into hemodynamic effects, pulmonary effects, effects on nervous system, effects on environmental pressure, and neurohumoral response. Now coming to hemodynamic effects, these can be mainly due to hypercarbia, intra-abdominal pressure, and patient positioning. Hypercarbia in milder form doesn't have any effects on hemodynamic system, but if it reaches to 65 to 70 mmHg, it has direct effect on serious system causing myocardial depression and vasodilatation, and through indirect action on autonomic system, it can increase heart rate, mean arterial pressure, central venous pressure, and pulmonary arterial pressure. To minimize these effects, we have to increase the milk ventilation and maintain normocardia and maintain IAP less than 50 mm. And increase intra-abdominal pressure causes direct compression of inferior ventricle, which causes reduction in venous pressure and decreased cardiac output, increased central venous pressure, and increased vascular resistance. This is a graph we can showing effects of intra-abdominal pressure on cardiac output, right atrial pressure, and left atrial pressure. As the intra-abdominal pressure increases, there is a slight increase in cardiac output and atrial pressures initially till 7.5 mmHg, but as it 30% decrease in cardiac output and stroke volume. Venous return and ventricular preload are the key determinants of cardiac output. The decrease in cardiac output is accentuated by hypovolemia and attenuated by hypervolemia. So, minimizing the duration of fasting, adequate pre-op hydration, and use of IAP less than 15 mmHg may reduce the decrease in cardiac output. And also, abdominal insufflation causes peritoneal stretch, which can increase the vagal tone and causing left ventricular systolic stress, increases the myocardial oxygen demand and thus myocardial ischemia. Hypercarbia can impair the hemoglobin affinity and oxygen transport can lead to MI. Optimal beta blockade is essential in these patients, and peri and post-operative pain management is also very important. But the overall instance of MI causing abnormal gas exchange, hypoxemia and hypercarbia, and these patients are unable to compensate for arterial CO2 elevation, which leads to significant acidosis, thus cardiovascular respiratory collapse, and particularly in baseline hypercarbia. Hyperventilation after intubation is necessary, and if acidosis develops and cannot be reversed, we have to convert it to open laparotomy. And particularly in severe COPD patients, higher airway patients require to ventilate with higher pressures, which cause to bulla rupture. And in obesity, these are associated with testicular lung diseases, diabetes, obesity, hypoventilation syndrome, obstructive sleep apnea, and chronically elevated IAP. So lower respiratory compliance, higher peak pressures require higher minute ventilation to maintain normocarbia, and further reducing the respiratory compliance and pneumoperitoneum. And venous stasis and risk of thromboembolism are also higher in these morbidly obese patients. And the final take-home message, to minimize these effects, we have to maintain IAP less than 15 mmHg, and we have to use slower insufflation rates, and we have to increase the minute ventilation to maintain normocarbia, and adequate pre-op hydration is important. Thank you.
Thank you, madam. You have covered entire effects of the body. Any questions from the floor? We will call upon our next speaker, Dr. Bhargavi. The topic is role of radiology in basic laparoscopy.
Hello everyone. I'll discuss the few points in the role of radiology in the surgeries of appendicitis, cholecystitis, and hernia. First topic we are going to discuss is on appendicitis. Here, ultrasound is the primary modality. However, it is less sensitive and specific than that of CT, as it gives the detailed anatomy of periappendiceal tissues and other abdominal structures as well on a single go. Here we'll see the normal anatomy of the appendix on ultrasound with normal caliber. Here is the dilated appendix, and the wall is clearly demarcated here, which is inflamed. Here is a focused CT video. We are following along the ascending colon inferiorly. We can see a normal caliber appendix, which is arising from the base of the cecum. No periappendiceal fat strandings are seen over here, thus representing the normal picture. Here is an appendicitis picture on a plain CT and a contrast CT. The contrast is helpful because the wall can be clearly demarcated on a contrast imaging than that of the plain one, which is differentiated clearly on these two images. We'll discuss the complications of appendicitis, which include perforation, abscess, peritonitis, septic thrombosis, gangrenous appendicitis. We'll see the few complications here. This is one of the appendicitis. A fluid filled collection in the RF, which is seen extending medially and involving the ipsilateral psoas muscle. However, we can see a clear normal psoas muscle on the contralateral side. Here is another focused video showing complicated appendix. We are following down along the ascending colon. We can see fat stranding along the peritoneum with fluid and few prominent lymph nodes. And we can see We can say tubular structure with calcification arising, which is entering into this collection, which is filled with air and fluid. Here the differentials could be perforation, gangrene, and abscess. It was perioperatively confirmed to be a gangrenous appendix. We'll know the other differentials of RF pain other than appendicitis. The other differential is mesenteric adenitis, which is most common. Cecal diverticulitis, however less common. This differential should be remembered. Here we can see an air-filled diverticule with adjacent fat stranding representing inflammation, which is extending along the circumference of the cecum. Epiploic appendigitis, here fat attenuating lesion is seen with surrounding diffuse inflammation which is extending into the adjacent cecal wall. And in this fat attenuating lesion, we can clearly demarcate the hyperdense focus representing the thrombosed vein, which is the cause of epiploic appendigitis. This is another differential, omental infarction. And the other differential that should be remembered is an appendicular mucocele. In this coronal image, we can clearly see the dilated appendix with thick content within, representing mucocele. It can be sometimes malignant, hence this should be ruled out with further investigations. The other differentials are right ovarian torsion, obstructing right distal ureteric and VIJ calculi. These are the different post-op infection presentations. Here, ultrasound is the primary modality of choice, as the basic or minimal collections can be identified with ultrasound itself. However, in rare scenarios where appendicolits are seen, suspected, we should go with cross-sectional imaging to further identify the location of the displaced appendicolith. This is a case of post-op appendicectomy. A fluid-filled collection is seen in the RF abutting the cecum, which was also confirmed in this axial section and diagnosed to be an abscess. It got resolved with further antibiotic treatment, which was later confirmed on the further imaging. We'll proceed to the next topic, cholecystitis. Ultrasound, however, is the primary modality of choice in these scenarios where including the bile duct anatomy can be identified to some extent. However, it is operator and abdomen status. It is dependent on the operator of the machine and also on the body habitus of the patient. MRCP is the superior modality of choice as it can give the anatomy and pathology as well. Here, in prior to cholecystectomy surgery, anatomy of the ducts should be identified to avoid iatrogenic injuries. We'll see the normal picture of the stones on an ultrasound. Here is a GB containing multiple stones. The infraductal system is dilated over here and we can identify a small focus of calcification within the duct which is causing this dilatation and also mild IHBRD. However, in some scenarios where we can't identify the stone in the ultrasound, if the ductal dilatation is reported in the image, irrespective of the LFT alteration, further imaging like MRCP is necessary to rule out distal obstruction. This is the normal ductal anatomy of the normal biliary ductal anatomy. We'll see the basic variants which we'll see commonly. Here's the cystic duct variant where there is medial insertion of this cystic duct into the CBD. Here is another variant where we can see the cystic duct and CBD coursing parallelly, which is confirmed on this axial image as well, where these two ducts are getting confluenced approximately at the level of ampulla, thus representing the low insertion of the cystic duct.
The MRCP image?
Yes, this is the 3D reformatted MRCP image. These both are 3D reformatted images and this is the axial section. No, so just we'll give the gastric agent, that's all, for the MRA, for MRCP, sir. And here are the other cystic ductal variants, bifurcation of cystic duct, absent cystic duct and short cystic duct. These are the three common intrahepatic biliary variants. which we will encounter regularly. Other variant is the axillary hepatic duct, which may be supravesicular or subvesicular. Extrahepatic ductal dilatation are categorized into these types based on the Todani classification. And the biliary leak, which is the most common post-op complication in different scenarios. These biliary leaks are classified based on this Strasbourg classification, and here are the different types. These are the post-op complications which we commonly encounter. These are retained stones, Mirizzi syndrome, vascular complications like pseudoaneurysm of hepatic artery or portal vein, dropped gallstones, ischemic cholangiopathy. In this scenario, MRI is the modality of choice because in diffusion weighted imaging, it can clearly demarcate the normal ducts from the ischemic ducts. Next topic we'll discuss about is ventral hernia. These are the different types which we'll see on the radiological imaging. Here the reports of radiology report should contain the type of wall defect, location, defect size, number of defect and size of the defect. Here is the normal muscular anatomy of the abdomen on CT image. This is here is an umbilical hernia with fat as content, epigastric hernia with fat and loop as content, spigelian hernia. Here the defect is seen along the left anterolateral abdominal wall with bowel loop and fat as content. Here is an example of lumbar hernia with bowel loop as content. Here the defect is seen along the posterolateral wall of right abdomen. Another common cause of ventral defect is rectus diastasis. Here the interrectal distance, if it is more than 2 or 3 centimeters, it is considered as a divarication or diastasis recti. Prior to the surgery, if in scenarios like large hernial defects or in multiple hernial defects, few reliable tools are necessary to be reported in a radiological setting in order to predict the ability to close the abdominal wall defect during routine hernia repair. These tools are rectus to defect ratio, which is also called carbonyl index, and the other is loss of domain. These modalities are helpful to avoid the post-op complications like increased abdominal pressure, which may lead to some severe complications. If the carbonyl index is more than 2, then routine surgical repair is sufficient. If it is less than 1.5, it may require additional component separation techniques or progressive pneumotherapy, or in some scenarios, preoperative botulinum injections may help to some extent. If the loss of domain is more than 20%, there is higher risk of surgical complications. In such scenarios, the preoperative workup is necessary with these tools to identify the post-op complications. The other post-op complications which we'll discuss in the later radiological imaging, these complications are higher in parastomal recurrent hernias, multiple hernias or with large defects, and bowel containing hernias. Here is a case of post-op ventral hernia repair where the uplifted mesh is seen on this ultrasound picture with surrounding fluid, which was confirmed on this CT image as well. Here the mesh is identified based on this tacker. The other complications is adhesions. In this picture, we can see the dilated small bowel loops which are seen closely abutting to the anterior abdominal wall, representing the adhesions. It shows few A fluid levels. These indicate acute or subacute bowel obstruction. These findings are confirmed and showed in this perioperative image. The other complication is recurrent hernia. This is a post-ventral hernia repair where a small bowel loop is seen between the anterior rectus muscle and the underlying mesh, which was confirmed on these CT images. We'll see another example of recurrent hernia where urinary bladder is the content. This is a post-inguinal hernia repair with mesh identified based on these stackers. And this is a case of post-ventral hernia repair. and was suspected to be having a fistula. Hence, enteric contrast was given, which is seen extending into a tract-like extension in the subcutaneous plane, thus representing and confirming the patent fistula. This is another example of a post-left inguinal hernia repair, where on this ultrasound we can see the mesh is closely approximating the urinary bladder, which was confirmed on this CT image. However, along this mesh, which is identified by TACR, a collection is seen, which is seen continuing with the urinary bladder content, and which was also confirmed on this picture. This gives the suspicion for fistulous communication. This was double confirmed again on CT cystography image, where the contrast given to the urinary bladder is seen extending into the collection seen along the mesh. We should always know the normal postoperative imaging findings to avoid overdiagnosis. These are the normal postoperative imaging findings. Finally, I conclude that with radiological role, patient care can be improved. Both the surgeon and the radiologist must identify ways in which radiologic studies can complement the emerging technology of lab surgery. Radiographic studies can aid in the preoperative, operative, and postoperative assessment of various abdominal problems now in the realm of laparoscopic surgery. Thank you.
Thank you, madam.
Thank you, speakers, for an enriching session. Thanks to the chairpersons for moderating the session so well. Now I would invite Dr. Vikram to take over the proceedings as we proceed with the inauguration ceremony.
Good morning, everyone. Now I will proceed to inaugural session. May I request Dr. K. Shivashankar, sir, to come on to the dais, please. He is my teacher while working in Siddhartha Medical College. May I request Dr. D. Anil Kumar, sir, Superintendent, Pinnacle Siddhartha Institute of Medical Sciences and Research Center. May I request Dr. Rahman, sir, to come on to the dais, please. He is the head department of surgery, Pinnacle Siddhartha. May I request our chief guest, Dr. K. Pattabhiramai garu, to come on to the dais, please. May I request Dr. Sudhakar garu Surupaneni, observer of our today's CME. May I request Dr. K. Lakshmikant, sir, to come on to the dais, please. He is Secretary MRC of South Zone Secretary of MRC. So I thank all my teachers. Actually, all of them are my teachers, except Sudhakar garu. So it's an honor and privilege to be here. We thought of conducting a CME. We youngsters who are trained under Palnveli sir of about 7-8 people. We thought that we'll conduct one workshop here. So that's why all my friends coming together, we doing this. And Anil sir, the guidance of Anil sir and Shivashankar sir and Rahman sir, we are conducting this. So Thank you, sir. Thank you, everyone, for being here. I'd like to request Dr. K. Lakshmikant, sir, to say a few words about training sessions in laparoscopy. Good morning to all senior faculty, teachers, and VIKRAM for arranging this whole session. See, the main, interest of AMASI is to spread the knowledge of minimal invasive surgery to the masses and at any small centers available in all over country. And founder President Dr. Palnimelu sir is very much keen on this live procedures in spite of all the hype of not being able to have these live procedures. Sir took a lot of pain to see that the benefit of live surgeries comes to all the surgeons because they can learn very fast. Give patients better care and causing less and less complications. And I want all of you to become members of AMASI, and even postgraduates can become associate members. The main interest is lot of programs are going on online and offline, and you can participate. So I congratulate VIKRAM for arranging this session so that you can learn firsthand and you can see what's going on inside the theater. And I encourage all of you to do these procedures from basic to advanced. Now we are doing basics. Though VIKRAM is trained to do a lot of advanced surgeries, he's trying to show the skill which can be transferred to everyone. Thank you. Thank you, sir. Thank you, sir. Thank you for kind words. May I request Dr. Shivashankar sir to say a few words.
Dear colleagues, very good morning. I feel the basic laparoscopy surgery training should be there for all young surgeons. It's at least 5 to 10 years after MS. It's mandatory. The things we should remember and we should refresh ourselves about the basic laparoscopy. Here I found the learned colleagues, they have given their experience to all the youngsters, which is very much helpful to all of us. Even at this juncture also, I am learning so many things. I hope this will be a good learning lesson for all the young surgeons as well as the post-graduates, and as well as a refreshing thing for the senior persons. Thank you very much.
Thank you, sir. Thank you for the kind words. And as organizing team, we are all together. So may I request Dr. K. Pattaviramai garu to say a few words.
My dear senior colleagues in the Days and young colleagues in the profession, I was surprised when Anil called me yesterday and said you are going to inaugurate this session because I am not a laparoscopic surgeon. I missed the bus actually, because in my age, at the age of when I was at 70 years age, the laparoscopy started picking up. But not to miss the bus, I went and attended a workshop by Tahamtan Udradia in Bombay, and then B. Krishna in Madras. Both are stalwarts in laparoscopic surgery, and they started the laparoscopic surgery in India. Moreover, Dr. Palnimelu is a good friend of mine. I visited his general hospital 2 or 3 times, not for learning laparoscopic surgery, just to spend some time with him, because we are so good friends. He used to take leave from his work for 1 day and spend time with me. Dear friends, you have got a good opportunity here to learn the basics of laparoscopic surgery. I am sure the topics covered up to now are the real basics. That means the anatomy, the physiology, and the radiology of abdominal wall, laparoscopic surgery, where most of it is involved. You learn by the anatomy itself, because in the beginning of laparoscopic surgery, they used to say a surgeon should train himself at least in 25 to 30 cholecystectomies and appendicectomies openly, then only he can go for laparoscopic surgery. But it's not true now. The laparoscopic anatomy itself is entirely different now. What you see in a laparoscope, the anatomy is different, and that you have to learn. That's why the laparoscopic surgery is picking up very well. And now the robotics are there to help the laparoscopic surgeons. It adds to the accuracy of the operation, and laparoscopic surgery is going to stay, and it is going to be the benchmark of doing surgery. When I was started practicing in 1974 in Vijayawada, there are no surgeons, leave alone laparoscopic surgeons, only 3 surgeons are there. I introduced the upper and lower GI endoscopy in 1983. I was the first person in Andhra Pradesh to start GI endoscopy. And then even the government sector also, Habibullah, who was the head of the department of gastroenterology at Usmania General Hospital, he came and saw my unit and said, yours is a better unit than me because I am using a Russian gastroscope, which is very hard to bend. I used to have the Olympus gastroscope and colonoscope, and that revolutionized and made it a point in all over the surgeons' conferences that surgeons should use the gastroscope like a stethoscope for a physician, because the intricacies of abdomen is not known till you put your gastroscope in and see what is happening there. But slowly, gastroenterologists came and they took away that. Friends, laparoscopic surgery is going to stay. That's what I said. And this is going to be the gold standard of surgery now, not the open surgeries, because the days of open surgeries are coming down, except for few operations where laparoscope. I'm joking with one of my laparoscopic friends here. If given a chance, you will do cesarean also laparoscopically. But that is difficult now. But still, laparoscopic surgery is going to be the bread and butter for all of you. Because you have to learn it, you have to do it, and you have to do it in a better way than many of the laparoscopic surgeons who are the first generation ones. The equipment is available, but the only one problem is there. Can this equipment be made cheaper so that the laparoscopic surgeons can go to the villages also and practice there for the rural masses? That will take some time, and Paranilulu is very much interested in that. He invented some of the gadgets with a cheaper cost, and he wants to take it to the villages. I am sure most of you are budding surgeons in the early days of your surgical career, and learning laparoscopy is one step towards your advancement in the field of surgery. I don't know how many of the medical colleges are teaching laparoscopy actually. Are you allowed to see the laparoscope in medical colleges? Yes, no. But you are not allowed to handle it. Only surgeons will handle it. Whereas the private sector is very much advanced in that. I am sure most of you, or at least some of you, are going into the government service also. And it should be a standard surgical procedure in government hospitals also. For surgeries like cholecystectomy, appendicectomy, and hernias, laparoscopic surgery should be the first choice, because it leads to less trauma, it is time efficient, and the patients are to be in the hospital for only one day. With all these advantages, the laparoscopic surgery is going to gain over open surgery. They are doing laparoscopic surgery even for thyroid, for breast, and everything. So, make use of the opportunity given to you here in this workshop on basic laparoscopic surgery. Afterwards, attend the advanced laparoscopic surgery also and become a good laparoscopic surgeon and serve the society. Thank you.
Thank you, sir. I will light the lamps. Now I request today's CME observer, Dr. Sudhakar Garu, to say a few words about connecting CMEs.
Thank you, Dr. Paddaviram Garu and other dignitaries on the dais and all the attending doctors. On behalf of APMC, I came as an observer. But before that, I was the first one to start laparoscopy in Vijayawada. In those days, I used to go to the Siddhartha Medical College whenever there is time for me and see the journals and books. 1992, when I was in the library of the Siddhartha Medical College, most of the journals are containing articles on laparoscopy. So I thought that unless we learn this modality, we won't survive as a general surgeon. So then the first laparoscopy was started in Hyderabad at Apollo Hospital and then at Nizam's Institute. One of my close friends, Dr. Somaraj, was the head of the cardiology in Nizam's Institute. And Dr. Satyanarayana, who was a head of the Department of General Surgery, he was basically a pediatric surgeon. But he was the head of the general surgery and Dr. Sastry was the second unit chief. I asked Dr. Somaraj to speak to them and he got permission from them. I used to telephone them and whenever there is a laparoscopic surgery posted, on the previous day I used to go to Hyderabad in the night and see the surgeries in the morning and take the next train to Vijayawada and come back. I used to do that for 1 year. You are all very fortunate that all these workshops are being conducted here and you can actually go to any laparoscopic surgeon's theatre and see the live surgeries. And you can also, if he permits, you can assist also. So you're all very fortunate. Actually, you can see any surgery performed in South America now in the internet. Live broadcasts are also available in conferences. So please make use of them. And this is not for gaining credit hours. You should aim to better yourself every day. Every day you can improve yourself. So it is for your knowledge improvement and your skills improvement also. And APMC is actually giving the reducing the credit hour for older people, and they are coming to the district headquarters and registering the doctors. You need not go suppose a person in Srikakulam is there, he need not come to Vijayawada and get registered. The office bearers will go to Srikakulam and they are registered. So these are all some of the changes that are happening. Thank you very much for this opportunity.
Thank you, sir. Thank you so much for those kind words. And I thank all the dignitaries to attend the inaugural session. Thank you, sir. Thank you, sir. As we are running short of time, there is no official tea break. So anyway, refreshments are being served on the back side of the hall. We'll proceed with the next session. Thank you.
Thank you to all our esteemed dignitaries for gracing the occasion. Now we move on to our next session. We'll start with the video sessions and then we'll go for the live surgeries. To moderate the next session, I invite our chairpersons, Dr. Venu and Dr. Lakshmikant. The first presentation would be by Dr. Raghavendra on anatomical aspects of appendicectomy. I invite Dr. Raghavendra.
Yes, Raghavendra, you can continue, you can start.
Yeah.
So as they're getting the slides ready, slides are ready?
Yes.
Take your time, no problem. Sometimes, like because of various computers and software, it'll take time. So please check your things and we can come back. We can go to next presentation.
I also invite Dr. Shashikant to come forward, please, to chair the session. Dr. Shashikant. Ready? Yes. Next, start this. So meanwhile, we'll proceed with the next presentation. Meanwhile, on anatomical aspects of cholecystectomy, a video-based presentation by Dr. Pavaneshwar. Yeah. Explain this. Ready?
As they're getting ready with the slides, these are some of the basic procedures like appendix, hernia, and see, it's every procedure, every person will have their own techniques and ways of doing, and we can always learn from them. Surgery is a process where every day till you stop doing surgeries, you keep on learning. And sometimes even seniors in the whole conference you may learn one point which is very, very important. So I think as they're getting ready with the slides, so like we have seen various people do various techniques even for appendicectomies, but once we realize that one technique is good, you stick on to it. Sometimes after years and years, suddenly you feel, I think, can we modify our technique? So even simple appendicectomies can be the most complicated surgeries, especially when you're dealing with mass, or you think it's an simple appendix. You tell the patient that everything is normal, and you go and see an appendicular mass. Your radiologist has missed, your clinical findings are missed. So sometimes even simple procedures can be very complicated. So the same way, like I think it's very important for us to be not to be very dogmatic and very overconfident with the patient. So it's always, we tell all our junior, postgraduates, just be cautious, especially just because you think appendix is a very easy surgery. Don't say the same thing to the patient. Tell them that often we come across is, if you're ready, tell me, you can start.
Michael, we are ready with Dr. Raghavendra's presentation. So
Yes, we are ready. Please, Raghavendra, you can come.
Good morning, sorry for the delay. I am Dr. Raghavendra, surgical gastroenterologist from Pradhutur. So my topic is regarding the anatomical aspects of laparoscopic appendectomy, and I am showing few different scenarios in these things. So the main anatomical thing consideration in appendectomy is identifying the tip and identifying the base. Rest of the other things are similar, like divide the mesoappendix and then deal with the base. So the anatomical landmarks for identification of the base are tracing the tinea coli, and the other landmark is the ligament of Treves, which is a lower ileocecal fold that points towards the base of the appendix. So these are the various port positions being practiced most commonly for the laparoscopic appendectomy. The first one where you see the umbilical port in the 10 mm and the other port in the left iliac fossa and the suprapubic region, and these are the different modifications followed throughout the world. But what I practice is a subumbilical 5 mm port for the working port, and then I preferably place a suprapubic port and I use it for the camera. So 5 mm camera port will be in the suprapubic region, and the other working port will be in the right iliac fossa, which I have been practicing. So the other concept of critical view, as in cholecystectomy, was advocated by Subramaniam et al. The critical view is once you point the appendix towards the 10 o'clock position, you can see the tinea coli directing towards the base, and you identify your terminal ileum at 6 o'clock. So this is just similar to that of cholecystectomy. You can confirm the base before ligating and decrease the chance of stump appendicitis rather than leaving a long basis in this case. So this is a short video where I have shown how the critical view of safety is seen. Here I am pulling the appendix tip, I have holded it, and you can see the tinea coli running towards the base, and then your terminal ileum is sitting at the 6 o'clock position down. So it is always mandatory to check the base by holding the appendix in various positions rather than looking at it single position. So now I am passing the instrument as shown in the figure, where you can see there is no further base left. The base has been reached, and now you can safely ligate the base and you can avoid the stump appendicitis. So this is the regular appendicectomy, but the special considerations that has to be noted while doing an appendectomy are, first is the retrocecal subhepatic appendix, and then in cases where there is a gangrenous perforated appendix, when there is an appendicular abscess, when there is an appendicular mass, appendicular tumor, and the other thing is when there is a normal looking appendix, and then Crohn's diseases. These are the different special conditions where we have to deal little differently rather than a normal the regular appendectomy. So I will show few other videos. This is a case of a retrocecal appendectomy, where most of the people follow the procedure of retrograde appendectomy, where once identifying the base, you can, previous. Video play out. Okay. So, but what I usually do is I try to identify the tip and then pull it out and take it out and then do it as a regular appendectomy. Here you can see I've identified the tip and I've brought it out and then I've completed the appendectomy as in a case of regular case, and double checking the base before ligating it whether I have completed my mesoappendix dissection. And this is another special case where you can see the mobile cecum, and the cecum is almost in the middle line. And in these kind of cases also identifying the appendix might be different, but you have to be sure enough before dividing or ligating it. This was a regular case, and this was a case of perforated appendicitis, and you can see the body was sloughed off. I am holding the body, but the base was clear, so I didn't had any difficulty in ligating the base and finishing this case. So this is another interesting case where appendectomy was completed, but as a routine check, when I've started looking for Meckel's diverticulum, then I found a surprise in this case, which I will, which is going to come. So you can see this was a Meckel diverticular perforation. There was a chicken bone that got stuck up in the diverticulum and was perforated to the tip. And this is another case. It was in a pregnant female. You can see the enlarged uterus in this case. And as you know, the appendicitis is the second most common non-obstetrical emergencies. So in this kind of pregnant female also, we have to take care not to injure or not to touch the uterus in any condition, because the uterus might profusely bleed, which will be difficult. This was the case with an appendicular abscess. I'm gently using my suction cannula to open the abscess cavity, and this was in the pregnant female. You can see the uterus downstairs there. So this was an appendicular abscess. The now abscess cavity has been opened up. There were approximately 30 to 40 ml of frank pus. She was initially treated by the obstetrician conservatively, but it was not got settled and was referred later, little later, 3 to 4 days later. So after draining the pus completely, then I've proceeded with the appendectomy. So I have not got the control to forward it actually. So this was another case of retrocecal appendix, where I've tried to create a retrocecal tunnel and was getting for the base. Now I've got the tip and I've started dividing it from the cecal attachments. And I'll skip on to. This was another case of perforated appendicitis with abscess, and it was also presentation was delayed. You can see the large amount of pus with. Here the main difficulty was I was not able to apply a loop beyond the perforated site. You can see the perforated site where I've tried it in multiple directions, but was unable to apply a loop. So what I see, that was the perforated site here. So main in this video I wanted to show when there is a perforated base or when there is completely edematous base, how to deal it with this. If you are able to apply a loop with at least a minimal damage, we can get over that. But here in this case, I have took a bursting suture along the cecum, and then I've placed an omentum, and then I've plugged it. So, and the rest of the pus in the pelvis and right paracolic gutter was drained. Usually regarding the lavas and drains, the concepts are getting different. Right now, most people are saying avoid lavas and keeping of drains, but it depends upon the personal choice. This is the drain placement. So I'll skip on to the next video. So in this video, this was an appendicular mass. The patient also presented little late. So the patient was not improved with symptomatic treatment and was referred to me. In this patient, I have tried and I have mobilized the cecum, and I was not able to find the appendix. You can see a lot amount of dissection has been done. I have mobilized the cecum. I have searched thoroughly for the appendix. But what I found was a large raw area over the cecum in this case. You can see the raw area over the cecum. Probably the appendix got sloughed off and got adhered to the cecum. In these kind of cases, when we encounter, we have to be ready to do a limited cecectomy or limited right hemicolectomy. Limited resection has to be kept in mind when we are encountering these kind of appendicular masses or unusual presentations in these kind of cases. I'll skip this video. This was another interesting case. A young male, when ultrasound was found to be appendicitis, they have opened. So they've initially tried open appendectomy. You can see the scar there. But because of the appendicular mass, they were not able to find the appendix. So the scar was closed and laparoscopic rescue was sorted rather than converting into a laparotomy. Here, once we got in, you can see there was flimsy adhesions, and the terminal ileum was also densely adhered. So they were not able to identify it in the regular McBurney's incision. So these are the dense adhesions, which I am not able to separate with the gentle suction cannula. Here, because of all these adhesions, there was mass and was not able to identify easily. So I've started getting down the adhesions and I've started releasing it. Slowly I've identified the appendicular base, and you can see the appendix was partly retrocecal and post-ileal. You can see edematous tissue all over there, gently separating it. So there was the appendix now. It was completely twisted and adhered to the posterior wall and behind the cecum. Once we identify the tip and base, appendectomy is a simple procedure, and its principle is dividing the mesoappendix and ligating the base. Only thing is, as I said, the special considerations in these kind of situations only, we will find it very difficult to do or complete an appendectomy laparoscopically. Now slowly dissecting of the tip now. That was the tip only. Yeah? Yes. Once we identify the tip, the rest of the surgery is similar to the regular appendectomy only. So the main problem, as I told, I've used to place a right iliac fossa port. Most of the times, if you are using a regular trocar goes in and it will be hindering the surgery and I have to pull back my trocar. So what I have done is I've resized my 5 mm trocar. You can see this is a regular 5 mm trocar. So this is a regular 5 mm trocar, and one short one I have resized it so that to specifically place in the right iliac fossa position or in thin individuals rather than to avoid the port going in and coming out. Okay, so thank you. And the final take-home message is any laparoscopic appendectomy, the anatomical aspects are simple. Only thing is identifying the tip and identifying the base, and the rest of the surgery is dividing the mesoappendix and ligating. And regarding the different methods of ligation, you can use either catgut loop or VIKRAM loop, any any absorbable loops or staplers or clips. All of them are almost similar, and none of them is superior to the other. Okay, with this I'll end, and I once again thank the organizers for giving me this opportunity. Thank you.
Thank you, Ravindra, for beautiful videos. And we go on to the next session by Dr. Pavanishwar. He's going to talk about anatomical aspects of cholecystectomy. Pavanishwar, please stick to time.
Yes, sir.
So because of lack of time, please. As the presentations are getting ready. So I think basic our take home message for all the postgraduates and the surgeons who are starting are no case is difficult, no case is very easy. So all cases are, you have to be very careful, no trauma to the surgeon, no trauma to the patient. So I think you have to send them safe. So always anticipate difficulties, be slow, and have a good radiologist help. Every case when you're operating, please tell when you're ready. We are just so as you're preparing your cases, I think your clinical findings, your clinical examination, and ultrasound all are very, very important. So I think as they're getting ready with that case with the slides, I want the next person, laparoscopic anatomy of the inguinal hernia by Jayadatta Power. Please get ready and you can go ahead. So as you can go and start presenting the next, as they're getting ready, I think we should be very clinical examination, the investigation or perfect before you take up these cases, because in the hurry to do cases, don't get into trouble. Power. Okay. So another important presentation, the laparoscopic anatomy of inguinal hernia. So by Jayadatta Power, you can go on as the other presentation get ready. Yes.
Very good morning to you all.
Yes.
Thank you, Vikram sir, for giving me this opportunity. So the OG game in any surgery is, of course, the anatomy. Anatomy is important. Without anatomy, it becomes Balaya's meme that the trouble becomes a struggle and struggle becomes the trouble. So because it's a boring topic, I had to put those memes. I had no choice. So I didn't want to bore you with basic anatomy, starting from what ligament starts from where and all that. I just wanted to keep it precise, which is relevant to laparoscopic inguinal hernia anatomy, and a very simple one.
out of the presentation that play directly, go out of the PowerPoint presentation and present it directly. Otherwise, go to the AVI and present it directly. I think the next presenters, please give your presentation in advance so that you can check it, so that these problems will not occur, because when we bring the presentations on the PowerPoint, sometimes there will be discrepancy in the whatever presentable format available with the computer people. So again, like as they're getting ready, inguinal hernias is again one thing which is the stopgap when you really want to go to the, it's a stopgap with lot of modalities available for repair. You see, when we started, we said, beginners first start with TAPP, then do TEP. Then lot of surgeons started TEP because TEP gets over, no need to suture. And now with the advent of robotic, again people are coming back to TAPP because most of the robotic surgeons are doing TAPP repair. So I think things keep evolving. But what we need to know is anatomy is very, very important. So basically, again, when we are operating in the very critical structures there, no patient wants a complication because they are benign surgeries, and like especially either if a patient has a recurrence in hernia or when the patient has mesh infection, nobody accepts it. So you have to be very, very cautious that you should see that every cases is when you talk about infection, that is sterilization of your equipments, especially when you're starting your hernia, see that you are sorry.
Again, I am Dr. Sudhakar. I am yet to be convinced that laparoscopic hernia repair is better than open hernia. Because in laparoscopy, they are doing unnecessarily more dissection than is necessary. I am doing the same procedure in the open procedure with transinguinal preperitoneal space dissection and putting a smaller mesh in the same area where they are putting a large mesh. And I am not doing any extra unnecessary dissection. And for the last 15 years, I never had a recurrence. I am doing the same place where I am putting the small mesh and fixing it all around. They are only fixing two staplers or whatever they call it. Thank you.
So, yes, sir. I think what sir has to be taken very seriously, because we have been seeing through various generations for the past 25 years, there are a lot of surgeons world over, still they operate open, nothing wrong about it. So only thing we are talking about mesh repair. Mesh has to be placed. There was an important article which came up recently which said, do we really need to put a mesh? So see, all these things will keep going on. So what is very important is, follow the standard guidelines, standard principles, what is going on, and you should not be doing anything as an experimental approach. The evidence should be clearly available that whatever you're doing is good for majority of the patients. There will be often some variations. See, for example, you're operating in a very periphery and you don't have adequate sterilization techniques, and if you are placing a mesh when the theater itself is you're not sure about, then sometimes you don't know, placing a mesh itself will be a difficult thing. So like that, you have to be very practical in your approach. So especially you're going to operate in a very small town where the sterilization mechanism is very, very minimal. then placing a mesh itself is a problem. So, even if you're doing an open procedure, sterilization techniques has to be the same. Even your open and you should see how the infected mesh looks like, multiple openings, multiple fistulas, and very difficult to manage. So I think that's the thing, first thing sterilization, next thing is open or laparoscopic methodology. I think when we started, I think we even saw Dr. Palnivelu sir open and used to place a pre-peritoneal mesh, how a senior surgeon was saying that. So it's nothing wrong. So, and don't feel bad that you are doing open. So open is a very beautiful procedures. They are also standard procedures and they have stood the test of time. So I think nothing wrong in doing open procedures. So especially if you are operating, even when you are operating and you have any difficulty. So we always, those days, in our NIMS, we used to have a separate, ready? Yeah, as you're ready, tell me. We are just waiting for you. Yes, we'll go back. Let's go on.
Yeah. So there are about 16 structures we have to be careful about. That is the whole point of knowing groin anatomy in inguinal hernia repair. As you can see here, this is an indirect hernia. So the iliopubic tract, a very important structure that has to be noted, forming the lower border of the hernia orifice. And inguinal ligament don't expect to be seen in laparoscopic anatomy. That can be seen in open surgery. That is the whole point of emphasizing this. The iliopubic tract, again, typical anatomy begins from ASIS and to the pubic bone, but this is more important in children or pediatric hernia repairs. There are many people who are doing laparoscopic IPT repairs. Then the hernial orifice, we have to locate whether it is medial to the inferior epigastric or lateral to the inferior epigastric, and also you have to note down the femoral part, whether there is any femoral hernia or so. So of course we have to remember that sometimes it can be both direct or indirect, or a direct hernia can also be, a long-standing direct hernia can also be coming from the other end of the inferior epigastric artery, mimicking like an indirect hernia, but that we have to be careful about. So this is the most important structure we have to save. It's like sir said, trauma to the surgeon and the patient both has to be avoided. So there's a vast difference. The most medial most part look like a white elastic thin band. Make sure you see that and cut whatever you're cutting. And testicular vessels, again, coming back from the, going into the canal or deep down, they form like two transverse bridges going into the canal. This is the whole point of showing this, and you have to be very careful while dissecting them as well, because that can cause bleeding. So these are very important triangles which you studied in textbooks, the triangle of doom, the triangle of pain and all that. So it is mainly containing external iliac vessels lying down next to each other, the artery and the vein. Most importantly, they are only covered by peritoneum and some amount of fat in slightly obese patients. So you have to be very careful while operating. Don't try to poke them or try to test them, and don't try to go and pull them. So try to avoid them and keep the layer intact as much as possible. And the triangle of pain, very important. There is if while dissecting, even if you go there and if the mesh is slightly hanging over there and you want to keep the mesh in place, make sure you use a suture, and also it can be absorbable suture. At least even if there is some nerve entrapment, don't use tackers on that side. If at all you want to fix the mesh, fix it with the absorbable suture. If there is nerve entrapment, eventually the suture will get absorbed and pain might get relief. There are, Dr. Conrad and all keep saying that try to use absorbable sutures in the triangle of pain. So these are, this again, it's a pale pink, yellowish shade. You can see more of fat there, and make sure you push the fat towards the wall so that the nerves don't get bared at all. So most important part is the inferior epigastric artery. You have to make sure that you keep observing that. Even in this, even guide you in TEP as well, to make sure you make the lateral bowel space. So these inferior epigastric, they run in umbilical fold and eventually they come across the vas deferens. So while dissecting, make sure that you are safe with both vas deferens as well as the inferior epigastric artery. So these are pretty discreetly visible during the surgery, and also better to locate all this and then start dissection. Medial umbilical fold is usually seen in most of the patients. The one which you may not see is the median one. You may or may not see in all patients. sometimes there can be a vessel inside this as well. So better to buzz it completely and cut it before you attempt to start the dissection. If at all you are starting with that. Some surgeons have habit of cutting the medial umbilical fold and starting the dissection, but however I prefer to start medial to that. Again, the supravesical fossa is important during a hernia repair. You need to push down the bladder so that you don't injure the bladder, and also try to maintain the layer so that the mesh doesn't irritate the patient's bladder in future. There are many patients who complain that there is some kind of irritability and they have some urgency and frequency is increased because of the irritation of the mesh. That also has to be taken care. And of course, everybody knows, it's a common knowledge that bladder has to be catheterized before the surgery. So these are the basic anatomy before starting the surgery, and the triangle of doom and triangle of pain we have discussed already, and this will be the bladder here. Like I said, the median fold, sometimes you may not be able to sew it, and the right supravesical fossa and the right umbilical medial fold is here, and the deep ring comes here. Yeah. See, again, you can see the vast difference crossing the medial umbilical fold, the two testicular veins forming the pampiniform plexus here. Yeah. Now you start the dissection, you incise the peritoneum, you enter the Bogros space, make sure you see the bone here, which is a lighthouse sign for everyone. And again, you are seeing the inferior epigastric artery here, and you are making sure that you are medial to that, and you're not touching it, and you keep separating it, and you locate the bone now. Now you're happy and satisfied. At least I believe that once I see this, I'm happy, and then I go for the lateral dissection. And also I make sure that I see the Cooper's ligament initially, so that I'm already preparing for tacking or suturing the mesh eventually. On the opposite side, you need to go about 2 centimeter across the pubic symphysis, so that the mesh coverage is good. And again, you're dissecting the hernia sac, you're retracting it at 3 o'clock and 9 o'clock you're dissecting. And again, the inferior epigastrium you have noted, this is the sac, the edge of the sac, and this you need to push that down. Try to be close to the sac as much as possible, so that you avoid injury to this testicular vessels and the vas deferens here. Don't try to dissect in this part. Try to stay close to the sac as much as possible. Again, the testicular vessels. Now this is the sac edge. You're lifting whatever is unnecessary, and only the sac is being pushed down. So don't try to go here, because there are all major vessels there. And a trick is that if you're not able to find the edge, try to pull out this sac which has gone in. You can find the edge there in the jumbled up area there. If you're not able to do that, just pull it out and see. You can see that there the peritoneal edge is already reflected. So corona mortis is the most important part. You can see about 25% of population there is an abnormal anastomosis that has to be avoided. Make sure that you don't do any blunt dissection there. Stay away if possible, and also there has to be a good amount of dissection so that the mesh doesn't fold and everything falls in place. So this is a simple case of TAPP. I'm starting the dissection. I mark the ASIS that side, and then I go in, push. See, the whole point is left hand is retracting, and all the fat is being pushed to the abdominal wall. And I'm still trying to search for the pubic bone. I have not yet found it, so I'm not moved away from there. Still sticking to it. So once I find it, okay, I'm satisfied. I go back to the lateral dissection. Again, left hand retraction down, push everything up as much as possible. There are some thoughts that sometimes the fold becomes too thin, the flap, but I still believe that even if there is a thin flap, it's not going to cause much damage. I would rather keep the fat on the muscle so that I don't injure any nerves. So lateral dissection continues. I slightly extended because there is a lot of traction on the flap. I wanted the flap to fall down. There's a patient with a long-standing hernia, almost 15-20 years. It's a small sac, but the patient did have history of 15-20 years. So there are some quite dense adhesions on that side. But since it was a small sac, it was easy to reduce. I just put up a easier surgery so that the anatomy identification is important. So laterally and medially I've dissected well. Now I'm going to attack the sac. That is the whole plan. That is what I prefer to do. First dissect medially, identify the bone, go back laterally, push all the fat to the abdominal wall, and then attack the sac so that it's easier. So this small fat fold had gone inside and was causing the whole hernia. So I'm trying to delineate the sac as much as possible before trying to start the dissection. Just like open surgery, how you get rid of all the fibers, chromatic fibers and everything. And even now I found the sac, and there is some amount of pseudo sac since it's a long-standing hernia. So I dissect that. Now there can be bleeding, so I try to use cautery here and there judiciously, so that the distal end should not bleed into the scrotum later. That is the whole point of it. I usually confirm that, and then only I leave the other hand. So sac dissection is done. Now we have to paratalize it, make sure that the cord moves medially. Yeah, like I said, just pull it out and you know that the peritoneum edge has reached and your dissection is complete. And then I'm doing slightly medially so that I can see the rest of the foramens. And now I'm parallelizing the cord as much as possible. Difficult assistance I had that day because our regular assistant was not there. So I was doing with an intern, so I had to struggle a bit. But all which starts well ends well. So like I say, it's slightly dense there. I'm struggling to actually release them easily. Finally I could. Then I'm trying to see the distance, how much I've dissected from the deep ring just before placing the sac and mesh, and some more lateral dissection before I'm satisfied. Now I'm just checking the bowel. It's always better to have that habit of checking the bowel once in a while, because once inside you're inside the flap and trying to cauterize something, you have not realized that you've touched the bowel by mistake. So better to always go back and check the bowel once. I've made that habit. I keep checking in between once in a while whenever I feel that I've used too much cautery or I've used it in the area of bowel. So now I am happy with the cord medializing there. So I'm going back again. I just check. So now I am just going beyond the midline so that I can easily place the mesh. Again, some more fat pushing it to the abdominal wall, trying to cover the nerves as much as possible. Yeah, so now I'm satisfied with the dissection. Just need to paratalize the cord some more and get the peritoneum down so that I can comfortably place a extra large mesh. So I am only holding the fat, I am not holding any important structures. I lift them up and I pull the peritoneum down as much as possible. Some more medialization of the cord, and now I feel it is quite good. And I go back to the lateral part and dissect as much as possible.
Power, as you are getting ready for the live session, finish your first.
Yes, I'm done. The dissection is complete. I paste the mesh and close the flap with a suture. Thank you.
I think very beautiful demonstration and description of the techniques.
Thank you, sir.
Thank you, sir. Thank you. I think next anatomical aspects of cholecystitis. Are you ready? Panisha, please keep to time.
Yes.
I know you would have prepared all slide beautifully. but keep it in time. The topic anatomical aspects of cholecystectomy by Dr. Pavaneshwar. The audiovisual people, please see. Yes, good.
Video part. Sorry, sir, I could not cover this video part because there is some technical glitch. So let me start with the topic anatomical aspects of laparoscopic cholecystectomy. You all, most of the people, young surgeons, laparoscopic surgeons, they are aware of this anatomy and everything. So because this is the basic surgery, appendix and chole, they start with these surgeries and they progress gradually. So before today's learning objectives will be mastering these anatomical landmarks and identifying the critical structures and applying safety principles and recognizing the various anatomical variations. So the surface anatomy is basically important because whenever you find some difficult gallbladders and you start dissecting, these are the areas where transverse colon and omentum can get stuck into the gallbladder fundus and body, and those relations are very much important while operating. And these key anatomical structures and all I am going to skip. So coming to this anatomical variations are how the cystic duct can join the CBD. There are a lot of variations. The one which we commonly see is it will join to the mid part of the CBD and within some angulation. And there can be sometimes a parallel cystic duct. Sometimes it can be a low insertion of cystic duct. So a lot of variations. The cystic duct can go posteriorly, anteriorly, and laterally. And regarding the cystic artery, also the most common one is the right hepatic artery will be entering posterior to CBD, and from there you will be getting a cystic artery. There are a lot of variations, like the cystic artery can be anterior, or sometimes it can be very close and parallel to cystic duct, or there can be sometimes dual branches as well. So whenever there is dual arteries, cystic arteries, there will be some amount of anatomical variations, like the artery can be anterior. So in one of the videos I have placed, but I'm not able to show today. So this is the most important slide of my presentation. Like whenever you start doing cholecystectomy, the most important structures that you need to identify are the first, what we call as R4U line. That is ruveal sulcus you need to identify, and then segment 4 base, and then umbilical fissure. If you start identifying this line, what happens is you have to stick above the line. Here, you have to stick above that line, and you need to identify the cystic lymph node, which may or may not be seen in each and every case, and you need to identify the CBD, whether there is any pulsating artery anterior to CBD. Here you don't find any artery in that image, but whereas if you find anything pulsating, you need to be cautious about the anatomy. Like there can be variation in the cystic arteries, like dual arteries, or the artery can be posteriorly seen sometimes. Most of the times we will find artery when you start dissecting the anterior peritoneum. And the critical view of safety is very much important for laparoscopic cholecystectomy. And even this you can't find in each and every case. This is a classical cholecystectomy, how it has to be done. But when you find empyema gallbladder or a gangrenous gallbladder, or in acute cholecystitis, you may not be dissecting, clearing all this fibrofatty tissue and demonstrating this hepatocystic triangle. In those cases, we have to bail out. We have to look for the bailout options. And there can be various anatomical variations of cystic duct as well. Like it can be a standard, like angular insertion, or there can be sometimes a parallel insertion. Long parallel insertion can be there, where the chances of injury to CBD are very high. And if you keep tenting the gallbladder too much near the infundibulum, what happens is the CBD will be get tented, and it will give a false impression that it is a cystic duct. And there can be sometimes a spiral insertion of a cystic duct. In this spiral insertion, what happens is when there is a stone in the cystic duct that is exactly posterior to the CBD, you can be misplaced or misunderstood, like in CM appearance that can be cystic duct CBD stone, but it is actually not a CBD stone, because a lot of times you may try to do a balloon sweep, but still the stone may not be cleared. In those cases, you need to have suspicion that it can be a spiral insertion of CBD.
and in a Mirizi or short cystic duct can be there. So those are the areas where you need to, where you should not go too close to the CBD. And these artery variations I have already mentioned you, like sometimes there can be aberrant right hepatic artery from raising from superior mesenteric artery, or there can be sometimes a Hampton's hump. The right hepatic artery can course into the hepatocystic triangle and it can be tortuous also. You need to be aware of those. And as I already mentioned, this reveal sulcus demonstration is very much important. It can be absent in 15 to 20% of the cases also. So the common pitfalls can be like confusing common hepatic duct for the cystic duct, and if there is any short cystic duct, if you are keeping too much traction, I told you, like you can tend the CBD. And if there is a suspicion or if you have doubt regarding this anatomy of biliary tract, or if you find any large structure which is of the caliber is not matching with your cystic duct, then or if there are any additional ducts that are entering into the hepatocystic triangle, then you can use intraoperative cholangiogram, or you can use ICG as well to find the to demonstrate the biliary anatomy. And there can be difficult areas like, as I mentioned you already, when there is omental lesions, acute calculus cholecystitis, empyema gallbladder, and gangrenous cholecystitis. So there we need to look for the bailout options. So regarding the bailout options, the first thing is you have to think whether to do for an open conversion, or you can manage laparoscopically. If you can manage laparoscopically, there are two options. There's in the subtotal cholecystectomy. The one is fenestrating type, the other one is a reconstituting type. In the reconstituting type, the chances of residual gallbladder will be there and the reformation of stones will be there, but that has to be explained post-operatively to the patient. In the reconstituting type, the chances of leak can be high, but still the cystic duct, there will be a bursting suture, and post-operatively you will counsel the patient for leak, and if there is a leak, you can go for a CBD stenting, or you can go for even sphincterotomy as well. So the tips to avoid this bile duct injury or to achieve this critical view of safety and use a controlled traction. Basically, fundus has to be kept traction towards the left shoulder and infundulum laterally, and dissect in the correct plane anteriorly and posteriorly. You need to remove the peritoneum first and look at the cystic lymph node if any. Then you start dissecting the cystic lymph node, followed by finding an artery, and then demonstrating clearing all the fibrofatty tissue and demonstrating the hepatocystic and calloid triangle, and then proceeding and lower 1/3 of the cystic plate as well. And then you have to start proceeding for any clipping of the important structures. Before doing any clipping, always stay back, take time and give a pause and then go ahead. If your sister or an assistant gives you some information, or if they are suspicious, if they have some doubt, just give importance to their decision as well, because you will be thinking like it is normal, but they will be seeing from the other end. So always try to give importance to the person who is suggesting you something. If you have any doubt, call for the help always. And if any case you have started but you could not complete, you have opened the gallbladder, no hurry, whatever safe dissection you can do, you just do it, resect it, and look for any bailout options like subtotal cholecystectomy. Place a loop around this gallbladder by dissecting the posterior wall. If even that cannot be done, just keep a drain and send to the hepatobiliary surgeon. So these are the key takeaways. So always master the anatomy. It takes at least 20 to 25 cases to do a safe cholecystectomy. Those cases should be done under observation. Later, once you start doing, always prepare for the good cases. If you find any bad case, there is no harm. Just do a diagnostic laparoscopy, and you can wait for 4 weeks if there is severe cholecystitis in the initial days. But if you are once experienced, then you can start doing every case. So these are the 10-point strategies for safe cholecystectomy presented by Ashok sir. And in this visualization of the CBD has been given 3 points, and most importantly calyx triangle clearance, and this two structures demonstration is very much important in this safe cholecystectomy. The SAGES guidelines also say like the one which we have discussed till now. I'm sorry that I could not present this video today due to lack of time and also the technical glitch. So I have included a lot of videos like difficult cholecystectomy, subtotal cholecystectomy, empyema gallbladder, everything. I'm sorry guys. So if you have any doubts.
Thank you, thank you. I think if there's time, we'll still try to put up these videos tomorrow.
Yes, sir.
So keep your videos ready. So as you are waiting, I think in spite of your videos, you are able to demonstrate what are the basic things we need to do. Always LabColi looks very easy, but it can be very dangerous also. Thank you, thank you,
sir.
thank you. And as you, we'll go on to the next topic, that is laparoscopic anatomy of the pelvis by Dr. Amruta. Please, please come on to the stage. Again, as the slides are getting ready, and the thing is, as you are planning for a basic procedure, no case, be complicated. The age at which you are operating, because of the laxity of the tissues, anatomy can be disturbed. So be ready. You are ready? Once your slides are ready, we will come back. So I think selection of cases and have a good radiologist with you. You are ready? Yes, ma. Amrita, you can go on.
Good afternoon, everyone. I am Dr. Amrita, and I'll be presenting on laparoscopic anatomy of the pelvis. I'm not sure. I will try to be very concise and not go too deep into gynecological anatomy. So in gynecological anatomy, the difference between open and laparoscopy, because of the pneumoperitoneum and we create, and we want Trendelenburg position to access the pelvis and pelvic structures. More so in hysterectomy, when we access the lower part of the uterus, we want adequate Trendelenburg to avoid injury and for good surgical exposure. So I think this has already been covered in port position, but just briefly going ahead, this is what we do. Our main entry, we go through the inferior crease of the umbilicus is our primary entry point. We do entry through varies, and supraumbilical port is our primary optical port that we use. We use a 10 mm supraumbilical port in case of hysterectomy and 5 mm port in case of diagnostic surgeries or minor procedures, if possible during cystectomy also. Now here, the supraumbilical port has to be made sure that it is in the midline. So if you go lateral, when you go, we go 2 finger breadths above the umbilicus as on an average in a normal size uterus. And when we face larger size uterus, we go slightly high. So the key here is to stick in the midline to avoid injury to the vessel and end up with a postoperative rectus sheath hematoma. Now our main operative ports are the lateral ports that we place 2 centimeters above and medial to the anterior iliac spine. This is the safe spot to avoid neurovascular injury, injury to the deep circumflex and the iliohypogastric and ilioinguinal nerve. If you go medial to the anterior iliac spine while placing the lateral pelvic ports, the patient might have post-operative neuropathic pain and chronic neuropathic pain sometimes that is not relieved with any treatment. Also, when we place the lateral pelvic ports, you can see here the inferior epigastric artery is at the lateral margin of the rectus. So we make sure to stay away from the lateral margin of the rectus. A rough guide is that to stay 8 centimeters away from the midline, or at least 2/3 away if you take the distance between the center of the abdomen and the lateral pelvic wall. There are lots of points that are described that we use depending on patient to patient. These are based on choosing the avascular areas like I have already discussed. So to avoid vessel injury in abdominal entry, for identification of the superficial vessels, abdominal transillumination is good, and for identification of the inferior epigastric, in thin patients we might see, and some patients we might not. So the lateral umbilical fold acts as a guide for the inferior epigastric vessel. Now these are the medial umbilical folds that were already discussed, but the importance in gynecology is that they form the lateral margin of the dome of the bladder. So in certain dissections, when we want to access superior vesical artery. So we trace the medial umbilical artery to the lateral edge of the bladder. Now here I would like to talk about certain things. You can see this is a posterior view of the uterus. We have inserted a uterine manipulator and the uterus has been completely anteverted, so it is touching the anti-abdominal wall. Now here, this is the round ligament that is extending up to the deep inguinal ring. This is the fallopian tube and this is the ovarian ligament, the ovary and the infundibulopelvic ligament. You can see this is the posterior surface of the uterus. This is the cervix. And this lateral part, the upper part is a broad ligament, and in the lower part, that is the central supports of the uterus, the Meccan rod, which is the main vascular supply to the uterus, where you encounter the ureter, uterine artery, and all that. And this is the posterior support of the uterus, the uterosacral. So here, the clinical relevance is that when you, let me come from here. So the uterosacral ligament has most of the nerve innervation, that is called the Franken-Hauser plexus. So when you deal with the uterine artery, there are certain surgeries where we suture the uterosacral ligament, especially when there is uterine descent, to provide additional support to the wall after hysterectomy. So we do not take a through and through bite through the uterosacral ligament because we want to avoid uterosacral ligament, number one, and also nerve entrapment. So that is one thing. Now you can see here there is pouch of Douglas. So here we use this space for two things commonly. One is for colpotomy when we do specimen retrieval. So we do the incision from vaginal end itself. We antevert the uterus like this. We access the posterior vaginal fornix and we give an incision roughly 2 to 3 centimeters below the cervical attachment. So that incision somewhere opens up here. Now you can see here, this is the ovary and the ovarian ligament. The thing to be remembered here is that whenever you are performing surgery on the ovary, it can be ovary preserving or removing the ovary. If you are removing the ovary, we cut here. So, and if you're preserving the ovary, you cut here. So you have to preserve the blood supply to the ovary. Often we see now there is very common incidence of premature ovarian failure that results because of surgery, iatrogenic. So that happens when you are not careful while dissecting here. If you go too away, when you are dissecting the tube, often we see after tubectomy also nowadays. So what happens is when people use cautery for tubectomy, the lateral spread will be there and there will be compromised ovarian blood supply that results in premature ovarian failure. So the key is that you have to elevate the tube, stay close to the antemesenteric border, mesenteric border of the tube and not go too much into the mesosalpinx. So this is the pelvic brim, the entry into the pelvis. So certain important things here is that this, as you can see, is the ovarian blood supply. This I had discussed in my previous slide. This comprises the ovarian artery and the ovarian vein. So when you coagulate here, if you go too lateral to the pelvic wall, there is a chance that you might damage the ureter. So you might do a simple salpingo-oophorectomy and end up with a ureteric damage. Now just a brief overview. The uterus is globular. It is wider above and it tapers as it goes down. So thing here I will just discuss about salpingectomy. So you can see here this is the fallopian tube. So the tube has a cornual end. This is the isthmus, the thinner part. This is the ampulla and the fimbria. So in tubectomy, your goal should be to apply the tubal clip sortings over here, the thinnermost part of the tube. Even if you're unaware of the anatomy, you just lift it and check for the thinnest part of the tube, that is the isthmus, and try to put your clips over there. And if you're cauterizing the tube in tubectomy, do not put your clamps too much into the mesosalpinx. Now this is just to show the round ligament. You can see here, the round ligament extends up to the deep inguinal ring and traverses up to the labia majora. Sometimes when we encounter frozen pelvis or in adhesions or in large fibroids or wherein endometriosis, the anatomy is distorted and we may not make sure clearly between the corneal structures, that is the round ligament tube and the ovarian ligament. In such cases, we trace it backwards. So we go to the deep inguinal ring, we check for the round ligament and we come behind and we identify the cornua. So this is anterior surface of the uterus. This is the bladder. So when we lift on the superior surface of the bladder, there is a tenting of the UV fold, and this is the plane that we go into when we dissect the bladder during hysterectomy. So these are the central supports of the uterus. So the anteriorly there is a pubocervical, and this is the uterosacral, this is the cardinal. This I've already discussed. The clinical relevance here is that between the bladder and the cervix, there is a small ligament. This we call it as the bladder pillar. I will just discuss brief steps of hysterectomy here. The round ligament, when we start hysterectomy, we start with the corneal structures. The structures anterior to posterior are round ligament, fallopian tube, and the ovary. So round ligament is around...
Two more minutes, ma'am.
Okay, sir. So we do not do very lateral dissection of the round ligament. It is 1 to 2 centimeters from the cornua. And the ovarian, I have already mentioned how to preserve ovarian blood supply. Colpotomy we do at the cervicovaginal junction over here. The main vessel is to the pelvis is the internal iliac artery. So I will straight away go to the uterine artery. So uterine artery is a branch of the internal iliac, like I have already mentioned. The key thing to remember here is that it has a transverse, ascending, and it anasmosis with ovarian. So when you coagulate the uterine in laparoscopic hysterectomy, this is the area, the ascending uterine, that you want to coagulate. Coagulating at the knuckle will cause inadequate coagulation. You will not be able to coagulate full thickness of the uterine. So this results in aneurysms. There is a uterine vein that is posterior to the uterine artery, and while coagulating the pedicle, you should try to include both the artery and the vein. If you go very below, so we have to coagulate at the level of the isthmus, and if you're coagulating very below, you can see the ureter is very close to the cervix, around 1 to 1.5 centimeter distance. So to protect the ureter, you have to coagulate at the level of the isthmus. So just a word about retroperitoneal anatomy. These are the common retroperitoneal spaces that are used in advanced surgeries and some retroperitoneal surgeries and endometriosis. This is the most relevant space right now for hysterectomy. This is the paravascular space. We don't enter it routinely. Only the important structure here is the bladder pillar that contains the lateral part of the bladder pillar has the ureter. So while doing hysterectomy and dissecting the bladder, you have to stay medial to this bladder pillar. If your dissection is extending lateral to the bladder pillar, you might end up injuring the ureter. So we try to separate the bladder from the cervix over here, this place. So just to peek into the pelvic side wall, the first layer is the peritoneum with the ureter. As I have already showed you this. Once you reflect the ureter, you see the pelvic vasculature, and then we see the operator structures. Just for completion, the nodes, these are all the pelvic nodes, and all the nodes are along the named vessels.
Thank you, ma'am. Thank you. Thank you for elaborative lecture, and we learned. And going to the next laparoscopic hysterectomy by Dr.
Good afternoon, everyone. I am Dr. Anusha from Hyderabad. So today we'll briefly discuss some tips and tricks about the safe TLH basically. So proper patient selection is always a key. So basing on the parity and being an nulliparous woman or previous cesarean section woman, you can anticipate difficulty in delivering the uterus. How much ever surgery you have done, ultimately you have to take out the specimen, and for that preparedness is the key. At times you might have need a morcellator ready or something. Again, coming to the indication of the surgery, again this endometriosis cases or large uteri cases, you might need extra help, or again the preparedness is required in this scenario. Uterus size, mobility, softness, firmness, approachability to the POD are all important factors before considering the surgery. Pre-surgical workup might always help you with a good ultrasound or MRI pelvis, and preparation for the surgery from patient side and from surgeon side. So coming to the basic steps of TLH, always once you put in your scope, run the diagnostics, have a quick plan and then proceed. There are roughly 8 steps. coming from the IP ligaments or round ligaments, tubo-ovarian ligaments, opening the UV fold, mobilizing the bladder, and securing the vessels, dividing the cardinals, vault opening, specimen retrieval, vault closure. Order can vary according to the surgeon, but planning is the key. Coming to the, in cases where we want to remove the ovaries, infundibulopelvic pelvic ligament is the first structure we tackle. And always antivert, antiflex the uterus, trace your ureter. Ureter crosses the pelvic brim. Once you lift the IP, you can clearly visualize the ureter. And medial traction is again the key. Always hug the ovary. Hugging the ovary prevents ureteric injuries and also gives you a good length of the pedicle. If suppose the ovarian artery retracts and it bleeds into the retroperitoneum, you can catch hold of it immediately and coagulate. And adequate sealing is always a crucial step because it's one of the major arteries. Coming to the round ligament. Round ligament seems to be very easy, but at the base there runs an artery. So adequate sealing is very important, otherwise it might start bleeding. Don't close the broad ligament folds once you open the round ligament and get into the plane that opens up the bladder, UV fold and everything. Tip is you pull the uterus contralaterally for tension. Don't divide too close to the uterus. You might end up injuring the ascending uterine vessels or parametrial veins. In the first figure, we can see like we have lifted the round ligament. My assistant is giving a good traction and I have taken an entire pedicle. And in the second picture, we can see I'm going into the anterior, into the broad ligament, lifting the anterior fold. Then coming to the uterovarian ligaments in common terminology. Before going into the ovarian ligaments, if suppose salpingectomy is needed, please do this, complete the salpingectomy because this gives a better stabilization. And as Dr. Amrita has told, like always stay close to the tube in the mesosalpinx, and this prevents the lateral spread of the energy and damage to the ovarian veins in the IP ligament. And preserves the ovarian function in a better in the long run. Always hug the ovary, avoids the injury to the ascending uterine vessels. In the first picture, you can see like we are very close to the ovary while dividing. In the second picture, it was a very large uterus, about 24 to 28 weeks, and I couldn't get any space, but with a lot of traction, I could get hold of the pedicle and divide it. So next topic, axial force from below or above. It's a very important concept when you are doing a hysterectomy. Why? Because here the traction counter traction concept applies. We are putting vaginal manipulators with a cuff from below. At times people use Mymer screw or a claw from above to retract to pull up the uterus. So this gives lifting onto the uterine artery from away from the ureter. Ureters are seen in the green color, and above that is the uterine artery. We all know the like water and the under the bridge concept, where ureters run below the uterine arteries. So lifting of uterine arteries gives a good surgical safety in terms of preserving the ureters. So there are various uterine manipulators. First one is a Stowe's Clemoferon, and the second one is Mangeshkar, where the claws generally hold the cervix, anterior posterior lips, and the cup fits into the fornix of the vagina. And assistant can handle from below, and the cup to close the vaginal orifice to prevent the leakage of the gas once we are opening the vaginal vault. The other manipulators are VIKRAM, where narrow vaginas are anticipated. We can use them. This is a Romies. And the last one is the sun pulse manipulator. Few people don't like to use any blue cup before cutting colpotomy. So those people, they take the simple elevators and have a uterine manipulation. Coming to the next step, bladder mobilization. It's one of the very important key steps. Identify the utero-vesical fold of peritoneum, as Dr. Amta has told, like proper lifting and gives you the reflection and open it and stay in the loose areolar tissue plane. And previous cesarean section, we expect a scarring wherein the UV fold can be fibrosed and adherent to the anterior surface of the uterus. It might seem very simple, but at times we end up injuring the bladder. So lateral approach to find a plane from after the round ligament, you can dissect down and stay above the uterine artery, stay medial to the uterine artery, open the plane and slowly identify again here the colpotomizer cup helps you in identifying the vaginal wall, and slowly you can dissect onto it and lift the fibers and go into the plane. Once you get the plane, it's all the more the same as a routine dissection. Then coming to the peritoneal reflection, if it is not at all clearly seen, then simply backfill the bladder, identify the upper limit and go ahead with the dissection. So again, the bladder pillars are the lateral limit of our dissection. They need a transection with the proper hemostasis. Dissect down to the level of anterior vagina, delineate the anterior fornix. Again, here our colpotomizer cup helps us. So in the first picture, I was lifting the UV fold properly and I could able to easily go into the space and dissecting in the areolar tissue. In the second picture, it was a previous to cesarean section where bladder was very densely adherent. We have dissected the round ligament and then slowly opened the space. As the uterine vessels popped up, we ligated and then went into the space. Coming to the bladder dissection, axial force helps in
Last 2 minutes.
opening the space and delineates the lower border. So, securing the uterine vessels, start after mobilizing the bladder completely. And here the tip is axial force with the manipulator or myoma screw pulls the uterus capillate and lifts the uterine vessels. We'll be securing the ascending branches of the uterine artery, and then we will be dissecting medial to once the vessels are secure. Again, here the concept of open hysterectomy applies. We apply the energy source perpendicular to the vessels. Once we seal them, we divide them, and again we go medially in the V-shaped cuts over to the uterus, medial to the artery to lateralize the vessels. Energy sources, proper sealing is required. Ligature and seal works better. When you're using a harmonic, prior bipolar sealing is required, and harmonic at the lower setting for the better sealing. Then coming to the Meckenrods and cardinal ligaments, in the V-shaped cuts onto the uterus, we will dissect the Meckenrods and lateralize them. Too much lateral dissection poses the risk of injury to the ureter. And uterosacrals, previously people used to cut the uterosacrals, now we are preserving them because they give a good supply to the vaginal wall and prevents the future wall prolapse. And if at all dissected, we need to attach them to the wall tangles. Colpotomy, begin anteriorly, make sure you have entered into the vault and then go laterally. While you are going laterally, seal the vessels with the bipolar and then go into the monopolar hook and open the vaginal vault. Here dry current gives a good dissection. Again, while extracting the specimen, gentle pull, if you get it out, it is okay. If it is a too large specimen, don't do excess traction blindly. It might tear up the vaginal wall. Do a cold knife morcellation or in-bag mechanical morcellation. Mastering the art of vaginal morcellation is the key here. And vault or cuff closure, again the same principles as open hysterectomy. We secure the angles, include the mucosa, go through and put a non-tension sutures, continuous sutures, and barbed sutures can be preferred because they give a tension-free repair. Too much of tightening causes vault necrosis, leaving the mucosa causes the vault granulomas. So coming to safety step. If in case you have done an extensive dissection, particularly in the large uterus or endometriosis, or if you suspect any thermal injuries, always go with a simple cystoscopy procedure. Even a simple hysteroscope can be passed into the bladder and checked into, and ureter peristalsis can be seen, dome of the bladder, walls can be examined. If there is any opening, we can identify then and there. Delayed thermal injuries can be missed on it as well. Energy source, always use a good energy source, optimal one, and be safe with your procedure. Use short bursts and prevent the lateral spread. While checking the hemostasis, decrease the intra-abdominal pressure to identify venous leaks. And troubleshooting scenario, always when there is a bleeding, be calm, suction, clear your field, isolate the vessel, seal it. Don't go blindly, don't dig in, particularly in the pelvic area. Bladder doesn't mobilize, use a sharp dissection, identify the plane, fill it, and identify. Uterine pedicles retract, just grasp, you have a very long length of the uterine artery, you can easily catch hold of it and secure. So all this routine post-operative care, particularly Foley's can be removed from 6 to 12 hours. These are surgical pearls, and thank you.
Okay. Thank you. It's a difficult topic to cover in a very short time. Thank you for covering everything. Thank you.
And we would like to thank the organizing team and Dr. VIKRAM for having us here.
Thank you.
Thank you so much to all the speakers. Now we will go ahead with the much awaited live workshop. The first case is a 54-year male who had been operated for a bilateral lingual hernia, underwent an open repair 4 years ago. Now he has a recurrence on the left side, and as our OT team is ready, we'll directly go for the live. Dr. Sarvani is the operating surgeon. Over to you people in VIKRAM hospital.
So as they're getting ready for the live procedure, so there'll be few guidelines which we'll be following. So don't get perturbed because the operating surgeons cannot reply to your questions. Any questions you can talk to the mediator and he will find out from him. Basically some guidelines have been placed by NMC basically to keep the patient safe and to see that the surgeon is operating is tension free. And the priority has been to teach. The priority is not to, I mean, for the surgeons to show off techniques or nothing like that, or any advertise any of the materials or anything. So the main modality is to teach you and learn combinedly all the techniques which are being constantly being modified or changed. So I think we over to the surgeon and the moderator who are helping us to see what's happening.
So Dr. Samantha will be moderating from the OT. Dr. Sarvani is the operating surgeon and Dr. Anita is the anesthesiologist. Over to you, team.
Dr. Sumanto is there. Am I audible?
రిసీట్ ఆన్సరా కొద్దిగా గుడ్ మార్నింగ్ ఆల్
Am I audible? Right.
మా ఒకసారి కనుక్కోరా స్టార్ట్ చేయాలి సార్
Cannot hear from there.
So my monitor is towards the foot end of the patient and anesthesia from the head end of the patient and so this is already operated case of bilateral inguinal hernia open surgery. We underwent long ago. Now we are doing a test in this patient and I will introduce the first 10 mm program. This is how this is how I created given incision from mid of the umbilicus to I have taken a 10 mm knife and given an incision from umbilical region to about 1 centimeter incision has been given 1 to 1.5. We can extend a little bit and after introducing it is separated between anterior and between rectus and posterior rectus sheet. I have created I have introduced my trocar and I have retracted my muscle and this is a 0-degree lens. I didn't straighten my gas. I didn't insufflate it. After introducing my camera 0-degree, I just introduced and opened up the gas. Konja head low. I am just waiting for the pneumo to be created. So you can see the gas. This is I think objecting. This reflection. Objecting, sir?
sometimes it so happens that like because understands or whatever, if you're not able to see the lighthouse signs, you can also try to create your lateral port by dissecting over the post-selector sheet, wherein you are pushing the intra-epigastric vessel to the rooftop and going as laterally as possible. So once your other, port comes in, and very difficult to see anything because even a small that can make your working very easy. And as you know, assistant surgeon, and because assistant surgeon should be able to show the structures very well. So many times when postgraduates or assistant nurse, we even had owls from because of because we have a very small video. So here if you see the insect lightning, even as much as possible. And nothing what we should do.
ఫస్ట్ ఫోర్ డేస్ ఇన్ ద స్టార్ట్ చేస్తారు మాట్లాడతాం సరేనా చేస్తాం షూర్ లెన్స్ అంటే అక్కడ కాదు లైఫ్ చేశారు చాలా మంది చూస్తున్నారు
Okay, done.
Section.
Section.
Sub. Sister, section ready? Clean చేసుకుంటారు. Clean. Baik, semuanya. Clean. Just to go space. ఇది ఆన్లో ఉన్నాను. ఆన్లో ఉందా ఆఫ్లో ఉందా?
మైక్ ఆన్లో ఉందా?
ఎక్స్ప్లెయిన్ చేయాలా? ఎక్స్ప్లెయిన్ చేయాలా? So this is actually a direct, you can visualize sac, and this is a direct hernia. Actually he was having a left inguinal hernia, but when we entered a TEP field, he was also having a hernia towards the right side too. And this is a lighthouse. So immediately after putting the port, the first thing I strike is the bone. So the bony prominence will give you whether if you are in right plane or not. So then slowly you have to dissect, you applying a minimal cautery. You have to dissect the areolar tissue. And never ever compromise with the smaller bleeders too, because usually a TEP plane is a very narrow plane, narrow area. The space is much compromised, and moreover if there is a blood field with any lens, the blood will be, you won't visualize properly. So I am using a hook with the monopolar cautery. I am just trying to dissect. There are few steps in TEP plane. Now what is it is like, first you need to create the port, then you have to enter, then hit the bone, try to push the peritoneum down slowly. Yeah. If you enter this areolar tissue, there won't be much bleeding. So slowly you can push the tissue down. Okay, now I am entering the lateral side. Hi, sir. Back. So now you can see the other part of the bone. I'll show you. Any hernia, you need to dissect the first the medial and then lateral, then you need to then you have to go near the sac area. Till then you have to dissect it. All this cobweb should be dissected. See, you are seeing there is no blood. If you are in right plane, you don't find any bleeding. Most of the surgeons, they use scissors and Maryland. They connect the scissors monopolar. So gently I am pushing the peritoneum down, as you can appreciate it. Slowly. Until you push the left side peritoneum down, don't try to put the port on the left side, because it may injure peritoneum and you may land up entering the peritoneum. So do not put any port. I feel the best instruments in any surgery is, one is Maryland, the second one is scissors. Here you can see the peritoneum. Slowly I am dissecting it. I am sorry. See, you can see, slowly I am bringing it down. I am just using a 0° scope till now. I haven't used any 30°, but you can use 30. What we were taught is 0° gives a good vision. Clean the lens once. This is the good part in TAP, like fixing the 10 mm trocar, so that the 10 mm trocar don't move in and out when you wanted to clean your lens. So Now I place the second foot. Instrument. Bowl holding. So now I have opportunity to use both of my hands to create proper space. Bipolar. First of all, don't panic when you see any bleed. Just apply pressure for a while. Suction. I think because of previous surgery, this is looking a little bit scar tissue is there. You have to create a space of this is a space of for space for ridges. You can identify the bone. I can see some scar tissue over here. See the bone. Suction. Now slowly I am trying to enter the lateral wall. This is the peritoneum. This is the lower border. Just slowly, gently you need to push it above. Slowly and gently. Midline. This is like a butterfly. butterfly technique. They flip, right? They flip their wings the same way. Any small bleeder, try to cauterize. Okay. So you can identify the pseudosite. Gently push the sac above. Whenever you are applying the cautery, try to see what exactly the structures you are burning to. You can see this indirect sac. Okay. So here comes the triangle of doom, pain. No, triangle of doom and triangle of pain is a mirror images actually. When you are using right hand, the left hand also should be used simultaneously. If not, as morning I have listened to one of the lectures, if you won't use your instruments in proper, if you are using only right hand also, so what will happen is you will be end up with musculoskeletal disorders. That's true actually. So you can see the pulsation over here, the major vessels, so don't go there. So now you can see the peritoneum over here, so slowly hold it and try to bring it down. I think because of fibrous tissue it is little bit dense. You should hold the tissues very gently, don't harm them. Slowly try to dissect it. So dissect it slowly. So now you can see I have brought down the peritoneum down. It was actually a little bit tough, but okay. See, you can see the low border. See? The main structure to be visualized is the vase. Kindly do not hold the vase while pushing the peritoneum down. I am using my left hand to dissect it. That's what I was telling you. Kindly use both the hands. Transfer, shift your energy to both the hands, not to the one. You can see the sling over here, right? So this is the vase. Okay. I pulled it down. I found a small bleeder. That is okay, I think so. Okay. See, my now you can see the bony prominence much more clearly. Now slowly I am going to bring this fatty tissue down. Bipolar, please. After seeing morning's Ayer's class, I was feeling a little bit difficult to use a monopolar because I've seen how much the current it conducts. As a surgeon, we learn daily, not only from during these classes, but everyone learns from the patient too. History, first thing, history also teaches us many things. See, one of our friend calls us to operate a case, so we need to go, but we don't know what exactly a history of that patient is, but we need to operate, right? So immediately we can't watch for the case. First we need to see the patient. That's what I'm telling you. History gives a lot of information. So right from patient we learn many things, and also from our colleagues, whoever is assisting us also, they give a good information regarding, because they scrub for with many persons, right? So they give many ideas too. So we should consider even their words too. It's not like we should think like they are inferior. No, we should follow their orders also. Sometimes it's good. కొంచెం పోట్ బయట కనిపిస్తుంది. థ్యాంక్ యూ. One more thing, don't use a continuous current, which is not good for the patient also, which you are not supposed to do. ఈ టైప్ పర్లేదు. Yeah, he is having bilateral hernia. Is that okay? This patient is also having a opposite side hernia too. Bipolar. Maryland. In TEP it should be a bloodless field. Why? Because not only for the visualization but also like to prevent seroma formation also. It will prevent seroma formation too. Here you can watch, see I'm using a sharp instrument, I mean like a melon towards above and a blunt instrument towards the peritoneum. This also you should consider, like, so that it won't, you won't harm, you won't create, like you won't enter into the peritoneum. So sharp instruments, anytime it may break, or peritoneum may, it may give away. Sometimes you may miss anatomy in cases if there is any recurrence or like that. So see for the opposite side. So then you can go back. God has got a soft corner on doctors, so that's why he had given two sides like mirror images, so that if you miss one, you'll have you can find your error from the opposite one. And one more blessing for the doctors, surgeons, is laparoscopy. So see, in the olden days, you need to verify twice or thrice if you are operating on a hernia case, the site of the hernia. But at least in laparoscopy, if you enter, you can identify. So that part, you are lucky. Suction, please. So here is the inferior epigastric. So lateral to it, I am dissecting it. Okay. Slowly I am dissecting, pushing it above. Okay.
తగ్గిస్తారా అట్లా పెట్టించేసి
మైక్ కంటిన్యూ వచ్చాను ఆఫ్ చేశాను.
చేయాల్సిన అవసరం లేదండి. హలో
Check, hello, check, check, check one, check, hello, 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 check, check.
अच्छा अच्छा अच्छा
And you wonder where you have gone wrong. Try not to go beyond your.
Yeah, hello.
So, is it TEP or TEP? TEP, I think, sometimes when you think very muscular, sometimes they go out to 15, but I don't know. How much do you use? I use and once from the section I come down.
Hello.
Hello, yes.
Oh man, good at last. So like, who is there? I hear Lakshmikant's voice. Then.
Jasti, I don't know, because according to this, we are not supposed to communicate. You can talk everything, all the steps.
Achha, achha.
And you are doing a very beautiful dissection. You are enjoying your procedure.
Okay, okay, okay.
You asked us with the clarity is very good. And please explain every step because everybody are interested. They want to know your technique.
Oh, anyone?
We have done everything, but we cannot communicate.
No, that's okay.
If I need out, we will talk to the moderator. Okay.
Okay. Anyone in the hall or all gone for lunch?
No, they are in spite of lunch.
In spite.
Audience are waiting to see this.
Good. What I will do is like, I'll show you the external picture right now. Okay. Top lights on chain. So he is like 70 years plus gentleman who has a bilateral hernia, and the ultrasound was showing I think a defect of 1.5 on one side and the other side also plus 1 centimeter. So here like I have marked externally. See if I'm not audible any time, please let me know, like, okay.
You can show me the camera, please.
Yeah. See the top the external image. So this is the head side, and I'm operating surgeon. Dr. Manasa is general surgeon. She is assisting me. We have Dr. Kohli from the anesthesia side, and Pavani is helping us from the nursing side. So basically this is the head end of the patient, and this is the foot end of the patient. So what we have done is initially before going for an E-tap axis, we have marked the thing. This is the right rectus and this is the left rectus. So somewhere here should be.
Please, you can use just lift the camera out, show the yes, yes, you can show it.
Acha.
The camera person please help us.
Okay.
Show the external markings. There a mask can but too close. You need to show from the head end camera person.
Artery. So this is the left side of the patient. Give me marker even much.
The audiovisual people, please show the external camera.
So this is the head end of the patient, and this is the foot end. So this is left of the patient and this is the right of the patient. So this is the left rectus, this is the right rectus.
External picture, we are seeing external picture, the camera person, please, you can just remove the lens and show. It will be easy. Just take out your camera, show the external.
Oh, I think that's the better thing. Just show me this.
That's easy. Yes. Because the people
But someone work.
It's a beautiful marking you have done, and you are not showing us.
So I will show from here. So you people can see this.
Just the image is gone, maybe the light has come out, please. Transmission. Fine tune the lens, please.
Which one are you seeing, from the camera? Or?
Only thing is the lens has to be made clear. Good, perfect. Yes, you are seeing now. The external
Okay.
camera view is there now.
Okay, that's fine. He's showing me, I think. Not. So this is the top end of the patient. No, focus cheyatledandi. You have to be dynamic. Means you cannot put a still picture there. Yes, this is nice. Focus on my hand, okay, so that they can see. So this is the top end of the patient, head end, and here comes the foot end of the patient. This is the marking which I have taken. This is the left rectus. This is the right rectus. So what I have done here is hold this. So I went 2 inches above the umbilicus, artery. I went 2 inches above the umbilicus, then I went around 3 inches laterally. I have incised I took a transverse incision, then took a transverse incision over the anterior sheath. I had split the rectus on the almost 2/3, 1/3, then created a space in the retrorectus space and passed this 12 mm port. Okay? Then by next port, these two are the almost markings near the anterior superior iliac spine. So that indicates the amount of mesh to be covered on both the sides. So this is the presumed arcuate line. Okay? So after that, then I went, put my second port 5 mm through the rectus, seeing that I am not injuring the inferior epigastric vessels. So once you create space through this 12 mm port, it is mandatory that the inferior epigastric artery is always towards the roof. So that is a take-home message for everyone who is doing TAPP, TEP, ETEP, ETEP, RS. Inferior epigastric should always be towards the roof. If it is at the bottom, you don't get the plane and it is likely to get injured, and which is usually a disaster. So then I created space on the left side. The first thing which I see is the lighthouse, that is the pubic bone. Once I entered the retropubic space, that is the space of Retzius, then I had put the second port after slightly dissecting the arcuate line, the linea alba, which in this case is slightly on the lower side, so I have slightly dissected and put the next 5 mm port. Okay? So,
perfect.
Yeah, thank you. Then we'll go inside and see what is happening. We had a slight bleed there near the umbilicus, so I can.
But very well controlled.
Yeah, it appears. So let us see. So no. See, this should not come, Mama. This should not come. So yeah, see, ETEP bilateral inguinal, like it has its own advantages and it has its disadvantages. So one is like technically it is far superior than the regular TAPP. Second thing is like you needn't suture much like what you do in TAPP. Okay, that's a big advantage, and especially for if there are combined hernias. For example, if there is umbilical hernia and the what do you call like a inguinal hernia, I think this is one good approach where you can do it with 3 ports like. Okay, so here is the pubic bone, like you people can see. See, this is the pubic bone. Go near, Amma, go near. Go near. So this is the pubic bone. Okay, is it visible?
Yes, visible.
Yeah, that's fantastic. See, whenever like my audio is off, like, please let me know. Okay. So then I am creating the spaces. It's like the natural things where you go. Like if there is resistance of tissue, then I'm sure that you are in the wrong plane. Here there are all natural planes. You have to just go in the natural planes, open it. See the other side inferior epigastric artery. It is towards the roof. Okay. So then see, I'm coming more laterally now. Going more laterally. Yeah, show me now. No, show me. Okay. So got it? Like this is the area which I have dissected. So this looks like the peritoneum, which I have separated from the sac. Okay. Now I am dissecting the peritoneum from the sac. Is it visible?
Yes.
Is it visible? Is it visible? Yes. Then you have to gradually peel it off, Sometimes like what the previous surgeon was doing, I think it was really stuck. Okay. So here the thing is, you should know the limits of dissection. So thing is like where exactly superiorly you should stop, where inferiorly you should stop, and where medially you have to stop. So this is the most important step in doing a TAPP or ETEP or anything. See here what I am trying to do is, so this is the femoral area, okay. So this is the femoral area, I am trying to dissect the femoral area also, okay. See the whole purpose of doing a minimal access inguinal hernia surgery is to cover all the orifices, the direct sac, the indirect, the obturator, and the femoral thing. Okay. See the vein there. So the veins there. Come back. So here the limit of my dissection will be exactly where the vas turns inferiorly. So go there, Amma. Go there. See the direction of vas. See the direction of vas. So it's turning more medially. It's turning inferiorly. That is the place where you should stop.